Good morning. So I love the fact that there's so much energy this early in the morning. And some of you were able to join us last night for a brief reception. It was the same thing. Our reception was scheduled to go from 5 to 6:30. I think about 8 o'clock we finally had everybody dwindle out and all of these things. I've been to a number of meetings like this, actually a number of them in this room, where in the morning nobody's talking to each other. Now, by the end of the day, they're all talking to each other, but at the beginning, it's like no conversation. So I think you've already made a huge stride toward doing what may be the single most important thing that could come out of these days, and that is to strengthen and build community among each other. So this is off to a fantastic start. It's good stuff. My name's Tim Turnham. I'm the Executive Director of the Melanoma Research Foundation. My job is to do a couple of things, to tell you a little bit about MRF, but also to welcome you here. But the real person to welcome you here is a representative of MD Anderson, who have graciously allowed us to come and use their wonderful facilities. They are always fantastic to work with around patient meetings and patient gatherings. And the faculty and the staff take their weekends to come here and meet with patients and to share information that they know will be helpful. I can think of no more gracious hosts that we've had across the country than the folks here at MD Anderson. Here representing them is Dr. Patrick Hu.
Thank you very much, Tim. I want to give a very warm welcome to you from MD Anderson Cancer Center. We're really honored and pleased that you traveled so far to be here in Houston, Texas, to be with us. We have a very strong commitment to the cure of ocular melanoma. Cancer therapy in general is undergoing a revolution. We're really learning a lot of the mutations or the light switches that turn on and off cancers. We are learning a lot about the immune system, and this is now being translated to patients. And we do feel that much better treatments for ocular melanoma are around the corner, and we're committed to doing that. We have perhaps the largest team of researchers and multidisciplinary clinicians, teams here at MD Anderson dedicated to ocular melanoma. You'll hear from many of them today, including Dan Gombos from ophthalmology and Bita Esmaili, Scott Woodman and Sapna Patel from medical oncology. But these are all oncologists, pathologists, surgeons that all meet regularly to just talk about ocular melanoma and how we can work in the lab, work in the clinic better, try to figure out this issue, because we think it's solvable, and we hope it's solvable within the next few years. And so we really appreciate the fact that you're coming here today to learn about this. We want to be a resource for you. We want to help you in any way that we can. We're privileged to work with Tim and his team in the Melanoma Research Foundation. We've been partners for many years, and we're very inspired by Sarah Selig, who has really taken her own personal passion to moving this field forward. So welcome, and we'll be around all day to answer questions or to help in any way we can.
I have to pull out my cheat sheet here, because if I don't, I'll forget somebody. It's also my privilege to recognize a number of people who have spent many hours in pulling together all that you'll see and experience over this next couple of days. The committee who have put this event together, starting with the chair of the committee, Becky Seelig, who I think is related to Sarah, maybe. So Becky, and so Esther Damaser, and Esther, I haven't even seen you yet. Where are you?
She's coming in shortly.
She's coming in shortly. Okay, no wonder I haven't seen her. I would have been hallucinating. Butch Ewing has been part of it. Butch, where are you? There you go, in the back. And Anne-Marie Montijo, where did she go? There you are. Molly Wookner, where did Molly go? I just met Molly last night. And Rob Cheek, who helped from across the pond. So Rob flew in from England for a 2-day trip here, and we're really pleased to have him here, and it's great to see you, Rob. It's good stuff. They worked with people on MRF staff, including Shelby, who's wandering around off to the side there, who does all of our health education programs, and of course Sari and Molly Stofa, who I think most of you know or at least know of through the online community. So it's a great team, and I think you'll see a great result out of all of this. So a little bit about the Melanoma Research Foundation. We were started by a melanoma patient who had cutaneous melanoma and was diagnosed stage 4. And the doctor said, there's really not a whole lot we can do for you. And she said, that's not acceptable. What do you mean there's not much you can do for it? And they said that we've not been able to find any solutions in melanoma. We've been working and working, and we haven't been able to find any solutions, and the only answer is to have more research funded. So she said, well, we'll find a way to fund research. And she started the Melanoma Research Foundation in 1996. And unfortunately, she succumbed to her melanoma not very long after that. But in very short order, because of her efforts and what she did with her friends and her family, we were able to fund our very first research grant. And we've been funding peer-reviewed, which means scientists review proposals and make sure the very best science gets funded. So peer-reviewed science. We've been funding peer-reviewed science for 16 years now and have distributed millions of dollars to more than 60 institutions across the country, including a grant to Dr. Hu here at MD Anderson and others here at MD Anderson as well. I have to say that the money that we have funded compared to what the National Institutes of Health or NCI funds is small, but we fund in ways that are designed to leverage change. We try to fund people early in their career who may be trying to decide where they're going to focus their energies and their intellect and their efforts to bring them into the melanoma field. And we fund people who have proven their ability to accomplish things in research and who have a unique idea that may be a little bit unusual or a little bit risky but has great promise. And they can't get funding for it because there may not be as much robust data behind it. So they have these kernels of ideas we know they can produce, and so we fund people like that. And we're trying to find those leverage points where we can change the scientific dialogue. We've also then, because of this, reached out to the patient community and used patient community to work with members of Congress to put pressure on the National Cancer Institute to do more in the area of melanoma. And that putting pressure on the National Cancer Institute, the NCI, has helped generate more funding, has helped include melanoma in a broader category of research efforts, including looking at the cancer genome for melanoma and these kinds of things. And so we find these tipping points, these leverage points, where a relatively small investment can actually have a disproportionately large impact. And what we've seen in the cutaneous melanoma field is that things have changed remarkably. 2 years ago, 2 drugs were approved for metastatic cutaneous melanoma after 13 years of nothing being approved. 2 more drugs will be approved within the next 12 months. And there's a whole list of other things that are working down the pipe for this. So I'm not saying that to contrast cutaneous melanoma to ocular melanoma, but rather to compare the two, because I believe that we're very close to being in the same place in ocular melanoma. We're kind of where cutaneous melanoma was just a short while ago, where on the surface not much has changed, but beneath the surface the understanding of what is driving this cancer is becoming more and more robust and more deep and more profound, and that will spill over to better changes and cures. So we're working at a time right now where I think we don't know when it'll happen or how it'll happen, but we will see change, and we will see it sooner rather than later. We can see a path where things will become different. And so it really, really is a time of hope. I'm way off field of talking about MRF, but this kind of comes back to our philosophy and our approach and what we're trying to do. See it important science, provide scientific leadership, engage the patient community in a way that patients become more informed, more well supported, and then can use their power and their voice to help accelerate change. We have worked with people who've had melanoma across the spectrum, mucosal melanoma, acromelanoma, ocular melanoma, since the beginning. But we were very pleased to be able to launch almost a year and a half ago now, the Cure-OM movement. And we did it, and we talked about this, if some of you who were here in Philadelphia a year ago, We did this because we felt like there was an unmet need. And if there's not an unmet need, then we shouldn't be involved in this. The last thing we want to do is duplicate efforts. We want to find ways to collaborate and work together. And so we launched this initiative. And I have to say, you'll hear more from Sarah about what we've accomplished in this time. But I couldn't be more pleased with the progress of this effort. And I think the single most profound evidence of that is the engagement around our website by the ocular melanoma community, which has become not only quite large, but extremely robust. And what I'm hearing from people who track these things and are so much smarter about this than I am, is that there's a level of engagement with our website by the ocular melanoma community that's pretty much unparalleled in terms of times visiting on pages and staying on pages and interacting with each other and the level of deep involvement. And I hope that deep involvement is useful and helpful to those of you who are here. And I believe the kind of conversation that we had when we started this morning and the kind of conversation we had last night says that it is helpful and useful and that people are building connections and building ties to each other that help and make a difference. We are committed, the Melanoma Research Foundation are committed to the ocular melanoma community. We've made good progress, I think, and we're hoping to bring what we believe are important characteristics into this field. And those characteristics are we want to be entrepreneurial. We want to be willing to take appropriate risk in trying to move the field forward. We want to be collaborative. We want to be transparent. We are... We have a 4-star rating with the Charity Navigator system. It's the largest ranking of charities in the country, and the 4-star rating is the highest rating that they give. We have had that rating consistently for the past several years. Fewer than 15% of nonprofits get that rating 2 years in a row, and we've had it now 4 years in a row. We want to be efficient and keep everything open for everybody to see. And we're open to your feedback and certainly welcome your feedback. So I've talked way too long. Before I turn it over to Sarah, I want to recognize a couple of people, and I want to make sure I get their names right because we just met. Jessica Anderson and Coriel Stout are both working with the Ocular Melanoma Foundation and are here. And they live in my neck of the woods in the D.C. area, so we're pleased that you're able to join us, and I hope that the next couple of days are useful and helpful to you as well. So thank you for being here. Sarah Seelig will tell you more about CureOM.
We're just having a little IT help in front here. So, good morning. Thank you, Tim. Thank you, Patrick. And thank you to all of you for being here. This is the third time I've stood up in front of a patient meeting, and I'm just always really overwhelmed and emotional to look out at all of you and just to feel the support and the community in the room. And so I feel it again standing here today, and just really want to thank all of you for being here today. I'm going to give a real brief overview of CureOM. We're going to dive into a lot of this in more specifics throughout the conference, and particularly tomorrow. I'm going to give a specific update from the CureOM Scientific Steering Committee, so on the research initiatives that we're working on. And then we have a whole hour about your engagement and involvement with the MRF and CureOM. And so this is a brief overview, but feel free to ask any questions throughout the weekend, and hopefully we'll cover everything by the end of the weekend. So let me, there are a lot of familiar faces, but a lot of new faces as well, and so I just want to introduce myself briefly. I'm Sarah Seelig. I'm an internist in Boston at Brigham and Women's Hospital, and I'm not in the ocular melanoma field. I, unfortunately, found out about ocular melanoma, like many of you sitting in this room, sitting in the doctor's office with my husband, Greg, when I was 29 and he was 34, and he was diagnosed with a medium-sized choroidal melanoma in his right eye. About a year later, Greg was diagnosed with metastatic disease. That was in 2007. And through sheer determination, perseverance, optimism, and I think a lot of luck, we turned what we were told would be 6 months into 4.5 years. And Greg passed away 13 months ago, just after turning 40. For those of you who knew him, you know the hope and optimism that he had. And when he spoke in front of a scientific meeting and a patient community, he exuded that hope and optimism for not only himself, but for the community as a whole. And so when we had the opportunity to turn what we had been doing since about 2007 to help advocate and organize not only for Greg and Greg's care, but for the ocular melanoma community as a whole, when we had that opportunity to join forces with an organization like the MRF and found the CureOM initiative, we really jumped at that opportunity and felt that together we could make a big difference. I think a lot of Greg's views and words lead us into CureOM's mission and really set the foundation for the organization. So I just wanted to share a few words that Greg has spoken at meetings like this before with you, and then lead into the CureOM mission and kind of where we are today. But these are words from Greg that I thought might be meaningful this morning. I've had the opportunity to receive many state-of-the-art treatments. We have a team of multidisciplinary doctors who now think with us, collaborate, and fight right alongside us. My fight, our collective fight, and the fight of many others in my position goes on. I am hopeful we can beat this. We have a vision. We want to identify and assemble a team of experts who can bring their collective experience, knowledge, and clinical expertise to bear on our condition. We want a team. We think the more minds we can bring together to look at ocular melanoma, the better result we might have. And finally, this community, this coming together, not only feels so wonderfully supportive to me, to all of us, but honestly, I feel in the end, this is what it's going to take to put an end to this terrible disease and find a cure. And so with that, I think that really sets the foundation and for our launching CureOM together with MRF. So the CureOM mission is to support research and accelerate the development of effective treatments and ultimately a cure for ocular melanoma through innovative strategies, including international and interdisciplinary collaborations, to improve the lives of people affected by ocular melanoma by creating systems and programs to provide education and support, and to advocate for the ocular melanoma community. So just briefly, we've already gone over the mission. I want to introduce you to our steering committees and some of the staff who you've actually already met. And then I'm briefly going to mention a little bit about the research initiative, but as I said, we have a whole half hour to delve into that a little bit more tomorrow. Talk about some of our patient and caregiver support resources, how you can support CureOM, and then talk about ways in which we hope to communicate with you and hope you'll communicate with us, and then some future directions we're working on. And again, a brief overview, we'll be diving into more all along the way. So I want to introduce you to our steering committee. This is our inaugural steering committee. We're really lucky to have these members. This is a rotating body. So over the course of CureOM's lifetime, we hope to tap into a lot of the wonderful resources, human resources in the OM community. But our inaugural steering committee are 5 people. This is 4 up here at our last meeting. Anne-Marie Montijo, myself, Esther Domiser, Rob Cheek, and Mark Weinzero, who's not pictured here. And it's wonderful to be working with this really dedicated group of people. They give so much of their time and energy, so I wonder if we could give them a round of applause for all of their hard work. So, as I said, it's a rotating body, so as the years move on, we hope to tap into some of you out there who may be willing to help as well. We're also lucky to work with a wonderful scientific steering committee made up of 15 members, and I'll go into this a little bit more tomorrow as well. But I'll just mention we have 2 co-chairs right now, Keith Flaherty, who's a medical oncologist at Mass General Hospital in Boston, and Bill Harbour, who's an ocular oncologist who was at WashU and now is at Bascom Palmer Eye Institute in Florida. There are 2 co-chairs. It's an interdisciplinary scientific steering committee made up of medical oncologists, ocular oncologists, biologists, dermatologists, and surgical oncologists represented from the US and Europe. And we find that it's very important to have it be interdisciplinary and international to really cover many different viewpoints. So we'll talk a little bit more about this tomorrow, but I wanted to introduce you to them today. I think we've sort of done introductions, but I just want to highlight, I think, today that the newest member of the MRF and CureOM team is Molly Stofa. Molly's down here in the front, and she has just come on as our new program coordinator, and we are just thrilled to have her. Many of you know Molly. She's been in the community. She's cared for her mother-in-law, Shirley Stofa, and her dedication is just really inspirational. And so welcome, Molly, and we're so happy to have you working with us. And I think we've introduced you to the other folks who are here. So briefly, I'll mention the research initiative, and then again, we'll go over it more tomorrow, but I couldn't not mention today that we have raised over $800,000 dedicated to research in our first 13 months of existence, and we are thrilled with this. We know that we have a long way to go, but this is a really huge beginning. And I think it's phenomenal, and it's thanks to the support of many of you in this room that we have been able to achieve this. So you'll hear more about this tomorrow. We've been able to hand out our first 2 peer-reviewed uveal melanoma specific research grants, and you have in your folders a flyer that gives you an abstract of both of those research grants. They're each at a level of $200,000 over 2 years. And the specifics are in your folder, and then I'll go over in a little bit more detail tomorrow during the update as well. And then we've held several scientific meetings already the past year, and we have some coming up, and some really important scientific collaborations and ongoing endeavors that I want to update you on as well. So I'll go into more detail with all of that tomorrow. But right now, I wanted to really highlight some of the patient and caregiver initiatives that we have to hopefully meet your needs. And as Tim said, we're really interested in feedback and communication from all of you. And if there's something that we're not doing that you think would be helpful, we want to hear from you. We want this to be really interactive, and we want to be available to you, and we want to be in communication with you. So some of what we have going on, so one is this meeting. This is an annual meeting we hold, the Eyes on a Cure Patient and Caregiver Symposium, and we're grateful to be here at MD Anderson this year. We've made the decision to try and move around the country to be accessible to people around the country. So we're here this year. We were at the Kimmel Cancer Center in Philadelphia last year. We're moving to UCLA next spring, 2014, and we have Dr. McCannel, who's going to be speaking to you today from UCLA. So you'll see her again next spring. And then spring of 2015, we're going to be back at the Kimmel Cancer Center. So we are committed to this program and are working to plan several years out. But that doesn't mean that we still don't want your feedback on a lot of this to make each year better. But we also don't want to leave you high and dry for those 11 months in between these in-person meetings. And so this year we have developed a pretty robust webinar series, and we've already held a couple, which you can see on the slide, in June and November. We have one coming up next month, which on liver-directed therapies. So if you have any additional questions from this meeting, or for people who weren't able to attend this meeting, or you might get a little bit different information, that will be in April, and we'll get the information up on the website soon. And then we have additional webinars planned for the summer and early fall, looking at psychosocial concerns. So our goal actually is MRFY to have at least one webinar per month. So we're working up to that. And some will be more focused on cutaneous melanoma, some more focused on ocular, but there's so many overlapping topics that we think will be important for people. So we're building up to have one webinar a month, so keep your eyes out for that. We also have a really robust online patient forum where people can communicate, ask questions, so take a look at that. In your folders, you have a card about our Buddy program, which is a really wonderful program, and we have people specifically who have received training to be ocular melanoma buddies and caregivers. And it really can be at any point, either if you know someone who's recently been diagnosed and is struggling, and could benefit from a phone buddy, please refer them. But if someone was diagnosed 5 years ago or in a low point and could benefit from talking to someone, that's a good time to refer someone as well. We also have a clinical trials finder on our website. So a lot of good resources on the website. These are just some pictures from our June 2012 meeting at the Kimmel Cancer Center. Dr. Sato's there speaking, and the wonderful team of social workers who helped us with our breakout sessions last year. So just a couple more slides. We can't do any of this without your support, and support comes in many different ways. These are some ways in which we've received some financial support. So through individual donors, and you can see some of our youngest donors on this slide. So you can see a lemonade stand by some kids up in the corner. I think they raised several $100s for CureOM. And then this young man down in the corner for his bar mitzvah project raised $6,500 for CureOM. So these are some of our youngest donors that I wanted to highlight today. Really impressive. And then we also are very fortunate to have corporate sponsorship from several organizations, which you can see here. And so these are some photos from some fundraisers. Up on top is the MRF Wings of Hope Gala in Denver, where we had a CureOM team. And then down below is the Universal Studios CureOM team. That was great. That was last year. And then communication. So we've already talked a little bit about the CureOM website and the interaction there. We also have, since our last meeting, have developed the CureOM brochure, which you should all have in your folders. There are more out there. And if you want more, either in your clinics or to hand out or to bring to your doctor's offices, please email us and we'll mail them out to you. You just let us know how many you need and where to send them, and we'll get them to you. We also have a quarterly electronic newsletter called Eye on OM. You can sign up on the MRF website to receive this. This past year, we had 2, and this year we're ramping up to quarterly. You can also follow us through social media, Facebook and Twitter. Both of our accounts we keep very active and try and get the latest information about ocular melanoma and CureOM in both places. So lastly, future directions. As I mentioned, we're in the process of expanding our webinar program. We also are working on developing a physician education program to help educate community physicians. We are hoping to be able to fund additional research awards in the ocular melanoma field. We want to continue to support local coordination and local support groups, and we also want to continue to support and help build additional awareness about ocular melanoma. So with that, I want to thank you all again, but also briefly just go over a couple topics on the agenda before we get started. So first and foremost, I'm speaking from experience. These meetings can often bring up different emotions and feelings for each of us, sometimes unexpectedly. And we want to acknowledge that and just make sure that you all feel very comfortable leaving a session at any time you need to, not attending a session that doesn't feel right for you at that moment. And also want to let you know that we have social workers around all day. So the social workers are going to be leading breakout sessions, but then we have 4 social workers who will be here throughout the day. And so please talk to Molly or myself, and we can put you in touch with somebody if you really feel like you need to talk to somebody. We also have set up a kind of a break area down the hall. We have tea and coffee and some chairs by windows down there. If you just kind of want to get away and be by yourself or talk to somebody, that's all part of the meeting too. So don't feel like you're missing out or that's a bad thing. This is the first year that we have concurrent sessions, which we're really excited to be able to offer, and the MD Anderson team has been wonderful in helping us make this possible. So I just want to alert you to the schedule. If there is a scientific session that you don't want to attend and want to try one of the concurrent sessions, all of the concurrent sessions are next door, except for yoga, which is down the hall near that sort of break area. And then the break rooms for the small group breakouts, the social workers will take you to those, so you don't need to know how to get there. All of the sessions are being recorded, so if you miss something, don't worry. We will have it on our website after the meeting, and for anyone who isn't able to be here, we'll have that available on the website as well. And I think the 2 last important things are restrooms are down the 2 hallways on either side of the rooms here. And maybe the most important thing is that you all have evaluations in your folders. And while you're here and thinking about things, we really want your feedback. And so jot notes down as you're thinking about them. We're also going to follow up with an online evaluation after the fact. So if things come up afterwards that you want to share with us, we're going to send those out as well. We really want your feedback to know how to make this meeting better for next year. So with that, I want to introduce our first speaker. So we have Ocular Melanoma 101 in this room, and we have Yoga and Mindfulness, Mind and Body Healing. I guess that will be out in the hallway. Is that right? Next door? Across the hallway, okay. So for those of you wanting to go to yoga and mindfulness, will be across the hallway. And for those of you wanting to stay for the Ocular Melanoma 101 session, I want to introduce Dr. Dan Gombos and Tara McCannel. We're thrilled to have both of you here. Dr. Gombos is an ocular oncologist here at MD Anderson, and as I mentioned, Dr. McCannel is an ocular oncologist at UCLA, and we're just thrilled to have both of you here. So thank you for being here. I also will just mention that at the end of each session, we're going to have time for Q&A, so maybe hold on to questions until the end. Thank you.
Thank you so much for the opportunity to speak this morning. You know, many of us who you'll hear today get a chance to speak around the country, if not around the world, to our colleagues in the field. But it's really meetings like this that are probably among the most important ones where we get a chance to present really the most critical side of things, which is the patient perspective of this difficult disease. In the end of the day, we all recognize that people who are diagnosed with uveal melanoma are someone's family member, someone's loved one, and we've dedicated our lives to addressing this disease. Actually, just a little bit personal things about me. I knew in medical school that I wanted to be an ocular oncologist. And I recognize now it'll be 20 years since I identified that. So we are hand in hand, in parcel with the patients, focused to addressing all aspects of this disease. And we recognize how difficult it is. So today and the next couple of days are really about you and your family members. It's about getting around this disease, understanding where we are today. Where we were 20 years ago is not where we are today, and where we will be 20 years from now, I'm sure, is not where we are now. And change happens very slowly. But over a long period of time, you see the tremendous advances that we've had. My father's actually an ophthalmologist, and so I get the perspective of what this disease was like 30, 40 years ago, which was very different than what we have today. So we're going to talk this morning from the perspective of ophthalmic surgeons and ocular oncologists. I will assure you that there is a wide variation in how this disease is sort of addressed individually, but there are some themes that you'll catch as we go through this, and we'll both be available later on to sort of discuss this in great detail if there are additional questions that come up, and inevitably there are. We've broken this down into two components. I'll take on sort of the initial diagnosis, and Dr. McCannel will take over sort of management, and there'll probably be a little bit of overlap. The first thing I just wanted to touch base on, and if you look carefully, I've put the words ocular in parentheses and bold. And ocular is a bit of a misnomer because melanomas of the eye can actually involve different structures. They can involve the eyelid, still ocular. They can involve the conjunctiva, which is that sort of saran wrap layer around the eye that has a sort of a red look to it. Or it can involve the uvea. And the uvea is the most common area that gets involved. So sometimes people use the words ocular and uveal interchangeably, and technically it's not correct, although we really do understand that when most people say the word ocular, they really want to refer more correctly to uveal, or even more specifically the choroid, since most uveals are in the choroid. So you'll see these terms being sort of used interchangeably, and it's like, well, do I have a uveal melanoma? Do I have a choroidal melanoma? Do I have an ocular melanoma? And the answer is sort of yes, depending on the specifics and the details. Most of us understand when you say ocular, you're probably referring to a uveal, or even more likely a choroidal melanoma. It has to do with the anatomy of the eye and the specific part of the eye we're talking about. So we'll talk a little bit about choroidal melanoma 101. Now, if you deal with most cancers in the body, you will find that most cancers of the body, you go to your doctor and something gets cut out, and then the doctor sends it to the pathologist, and the pathologist says you have X. And so much of cancer is dependent upon the pathologist and the correct diagnosis. In fact, if any of you have so-called cancer policies, one of the most interesting things about cancer policies is it requires a pathologic confirmation of cancer. One of the things that's more unique about eye cancers is more often than not, we are very accurate in making a diagnosis of a cancer by looking at it, by looking at features about it. And people are always amazed by that. How is it that you can just sort of look at something and decide that something is or is not a cancer? And I just want to point out a major study that was done years ago nationally, in fact internationally, called the Collaborative Ocular Melanoma Study. Now, there are a lot of issues about that study, but one of the fascinating things about that study is that study involved in part removing people's eyes. And out of over 1,500 eyes that were reviewed, only 5 did not in fact have the correct diagnosis of uveal melanoma. So if you go to your physician and you're trying to wrap around the concept of how is it that someone can just look at me and tell me that I have a potentially lethal cancer, it's because we have developed a series of non-invasive tests to help us come to the correct diagnosis. And you'll see in some instances we do end up needing tissue, but historically, and in fact, historically and for purposes of diagnosis, we're actually very good at coming up with the diagnosis without tissue. And like anything else, it's not just sort of a simple process, it's a multi-step process. It involves doing all the things that your clinician is going to do in arriving at the correct diagnosis. One of the questions I get asked all the time is, how is it that I can have a cancer? I have no pain. People somehow equate pain with cancer. And of course, it's usually a painless loss of vision that is a more common scenario than a painful situation. In fact, only when the eye deteriorates or becomes quite advanced do we have to deal with issues of pain. So we get this sort of, a basic understanding of the history and the symptoms, and that's a component of arriving at this diagnosis. You'll also see that we use a series of things that when we look inside the eye, you may hear certain terms, and I'll show them in the next slide, but we use a series of things that sort of help guide us. Does this look like a regular mole? Does this look like a suspicious mole? Or is this in fact a cancer that we really need to worry about? And then any of you who have had this disease know that we use ultrasound a lot for eye cancers. Ultrasounds are a very important part of what we do. It helps us make the initial diagnosis, and then it helps us follow up with things. And over time, we've learned that ultrasound can be a very significant, important part of getting it right. And then finally, we sort of put it all together. It's not one thing that gives you a diagnosis of a uveal melanoma. It's all the things putting it all together. And then finally, while rarely we do need tissue diagnosis, sometimes we do. Sometimes these things don't add up just quite right. It doesn't fit quite well. And sometimes we do have to go in and get tissue and confirm the diagnosis one way or the other, although historically that's quite rare. And then I'll talk just briefly about other reasons why you might want to get tissue today. So how is it that we look in the eye? Well, there are instruments that have been around for probably over a century, and the main instrument that we use is called an ophthalmoscope. Ophthalmoscope, there are various ways in which that can be done, but basically, if you've ever gone to the eye doctor and they put this big black bulky thing on their head, they're looking at the back of the eye, and they're looking at the structures inside the eye. And then if you've ever heard your doctor sort of review what they're looking, you may hear different terms that are sort of being used left and right. And those terms may not be specifically explained to you, but what they are a series of things that are sort of saying, okay, is this looking like a melanoma or is this not looking like a melanoma? And we've learned through various studies that the appearance or the lack of appearance of certain features sort of guides us as to, is this more or less consistent with a melanoma? So that's why you'll hear terms, and you may look at your medical records and see things like the words drusen, orange pigment, fluid, RPE, which stands for the retinal pigment epithelial changes, or the terms halo. What we've learned from various studies is all these things combined, their absence or their presence, are diagnostic tools to help us come at the correct diagnosis. So that's why you'll hear those terms sort of being tossed around, but you may not actually hear that term one-on-one with your physician. Sometimes people come to us because there are other physicians who've been monitoring suspicious things and they notice clearly a change. So photography is another big part of this diagnosis because we take pictures of things that we're not necessarily certain of, and then if time demonstrates that it's clearly changing or progressing, it's time for us to reevaluate things. So every time you come to an ophthalmologist and there's any sort of concern or discussion about this diagnosis, photography is a key component. And as I'm often fond of saying, if it was on your skin and we had any worry, we would just cut it out. It's not the same thing as it relates to the eye. So observation of suspicious areas and then treating it if we do see concern or change is a component of what we do. Angiography is a dye test, and some of you may have done this the first time they were sort of talking about the possibility of melanoma. It's used a lot in the field of retina. It's actually commonly done. So it's a vegetable dye, basically, that we inject in your vein and then take pictures of the back of your eye. Historically, everyone used to do this test. Now I'd say some people use it, some people use it less. You still find it in the field, and I think you'll find a number of people still do it. But without a doubt, the single most important test that your eye doctor does as it relates to this disease is the ultrasound. There was a professor named Jackson Coleman who at one time was the chairman at the Cornell University in New York. He was also at the Harkness in Columbia. And his whole field was ultrasonography. And we learned a lot about identifying cancers of the eye with ultrasound. You don't need to really worry about all the squiggles that are on the screen. But what you need to know is that when we look at all those squiggly lines, there are patterns that we're looking for that, again, are helping us in sort of deciding, number one, does this look like a melanoma? And number two, does it have features that we think we could potentially treat with various forms of treatment, sometimes radiation, sometimes not. So ultrasound is probably the single most important non-invasive tool we use. And then there's this whole issue of looking for cancer elsewhere when you're diagnosed. Very controversial area in our field. And to suggest that there is a uniformity among physicians about how this is done would be incorrect. You will find a spectrum of approaches, and I think we are in flux in the field as to what are the appropriate tests to get at baseline and at follow-up. And depending on your team, you might get different answers to these questions. And as opposed to trying to figure out, is there a right answer or a wrong answer, I think what you can be convinced of is that every team has thought about this approach carefully and have come to what they think at this juncture the medical literature is best for their patient population. That said, we're always open to discussing things with patients. I don't know any physician who isn't open to discussing various options with patients. But you may get something as simple as some blood work. You may get something more complex like an ultrasound of the liver, a CT scan of the liver, a PET CT of the body, or even a liver MRI. And there is no uniformity. That's sort of the critical thing. But we are primarily looking at the liver. The last thing I'm going to touch base on is an area, again, where we are in flux in the field. When I entered this field, the teaching was you never entered the eye unless you absolutely had to. It was leave the eye alone, don't open the eye. It's best not to do that for various reasons. And then there's been increasing desire to sort of get a little piece of tissue, a biopsy, and there have been a number of studies, both in Europe and the United States, that suggest that perhaps we can stratify or take a segment of patients that are at very high risk for spread and a set of patients that are at low risk of spread. And so there is an increasing amount of ophthalmologists who are offering this test for their patients at the time of diagnosis. Again, the field is in flux, so when a physician brings that into their practice is varying. There are some physicians who are still not incorporating this in their practice. There are other physicians who feel strongly we shouldn't do this because the treatments that are available are not really up to speed yet for metastatic disease. So there are people who wear this test but consciously choose not to do it. And then there are various ways the test can be performed. And so even if you get a biopsy, there are different tests that are out there. And the two big ones are either a chromosomal test or gene expression profiling. So right now, depending on where you're treated up front, and depending on how long ago you were diagnosed, this concept of biopsy may or may not have been introduced, and may or may not have been offered, and may or may not be available to you today depending on the treatment that you had. So even within the field, I think we are continuing to see differences, but we are clearly leaning toward, and certainly big centers like us and UCLA and other centers that are involved, are inclined to prognosticate, in part because we have partners in melanoma oncology who can help us with the particular subset of patients that we know are at very high risk of spreading. So with that, I'm going to let my colleague, Dr. McCannel, take over, and we'll go from there.
All right, well, I thought that was a terrific talk, Dan. I mean, I think he really put it nicely together. I just want to say it's just a real privilege to be able to come here today, and just listening to Sarah and this whole organization. I don't think I've met anybody like Sarah who can harness a bunch of ocular oncologists and doctors together and get them in a room and start talking about productive work together. I've never seen it until I met Sarah, so I think you have a wonderful leader with us. So I'm from the University of California, Los Angeles, and I had the opportunity to have the chance to come out here for this weekend, and I'm really looking forward to spending some time and maybe getting to know some of you a little better.
So we need you to pull
We
up
all set?
No, you need to.
Oh, okay.
Yeah.
So let me pull up my talk. Let's do that.
Just continue without scanning.
Uh,
Pull out for me.
oh,
No. And then
sorry. Is
Close
there-
me out.
Okay.
And then go to computer, I think. Go to
Is it down here? Yeah, please. It's been a while. Let's see. It's Cure.
I think that's like 13.
Yeah, that's it. That's it. Okay. Right. So my part of this this topic is to talk about some of the treatment options, clinical follow-up, what you can expect and what your doctors are doing at the examinations, and just touch a little bit on systemic follow-up, looking at the rest of the body. In general, when we talk about treatments, there's the main treatment that most people are offered is radiation therapy. And that's usually because most of the time these tumors are diagnosed, they're small enough to be able to have the eye saved. However, if the tumor is diagnosed when it's very large, then we usually recommend enucleation, which is removal of the eye, because the eye usually can't tolerate the amount of radiation necessary to kill the tumor. And then there are other forms of treatment, such as laser or different surgical approaches that are much less common. So I know that Dr. Gombos touched on the collaborative ocular melanoma study, but one of the most important things that we've learned from this big study is that there is no survival advantage if you have the eye removed. A lot of times when I'm diagnosing a patient, they say, why don't you just take the eye out? I don't want to have this in my body. But this study showed that whether we take the eye out or we try to save the eye and save some vision, there isn't a difference in the mortality. So because of this, eye-saving treatment is recommended when possible, because patients can keep your eye, and in many cases there's a chance to maintain some vision in the eye. So what about the different treatments? Let's talk a little bit about radiation, and I don't want to get into too many of the details, but brachytherapy and the use of iodine-125 plaque is the most common type of radiation treatment for this. In Europe, using a different isotope, ruthenium-106 is very common, and also palladium-103 is another type of radioactive isotope that can be used. Probably the second most major form of radiation treatment is with proton beam radiotherapy, and that's instead of having a plaque on the eye to treat the tumor right there, the beam shines into the eye and treats the tumor that way. And certainly there are other forms of radiation, external beam, gamma knife, stereotactic forms of radiation that frequently are used on larger sized tumors. So here's just a picture of a typical iodine-125 plaque, and you've probably never seen this because it may be on the eye and you don't get a chance to look at it, it's sort of in plain sight here, but this is the back side of a plaque, and you can see the little silver beads there. Those are the iodine seeds. That's the actual radioactive part, and the gold plaque shields the radiation, and that's what keeps the radiation really limits the radiation externally. And what about enucleation or removal of the eye? As I said, this is usually reserved for larger tumors that cannot be treated safely with radiation. And then afterwards, the patient is fitted with a prosthesis. And here's just what an eye removed may look like, and you can see at the bottom the melanoma is that sort of whitish structure, and this is a typical, when the eye is removed, this gets sent to the pathologist, and they often create a section like this to be able to study the tumor and the tissue from the eye. And we'll touch briefly on laser and surgery. There's a treatment called photodynamic therapy, and sometimes this is not a very common form of treatment, but for some people that have very small tumors, this is a possible treatment that some people use, and that's when you get a dye into the vein and then a low-intensity laser is delivered to the tumor to treat it. And then there's something that we call TTT, or transpupillary thermotherapy. This probably is falling out of favor as a primary source of treatment, but certainly can be used as an adjunctive treatment together with plaque brachytherapy. And then in terms of surgery, there's not a lot of situations that we usually recommend for surgical resection, but oftentimes an iris melanoma, because it's so usually very limited, these can be surgically removed. And then sometimes if there's a small tumor in the far periphery or sort of away from the back of the eye, sometimes these can be removed as well. And here's just a picture of an iris melanoma before and after treatment. You can see the little brown tumor there at the bottom, and then it's cut out, and then the iris is joined together after the resection. What about the examinations and the visits to the ophthalmic oncologist if the eye is saved? So you've had some sort of form of radiation treatment. And usually all of us recommend that you have routine examinations to do a few things. You want to check that the tumor is continuing to respond to the treatment. You want to look for side effects of radiation, and you want to check the health of the uninvolved eye. We get so caught up with the eye that's had the treatment and how that's doing, we sometimes forget about the fellow eye, but it's critical to check that eye, make sure that that eye is in the best possible health. And then what I always want to do is remind people to, continue to have your systemic follow-up and check on what tests are being done, and if there's any new information or trials. This is the time at your visits to talk about it. So I know that a lot of patients after the tumor is treated, they ask, well, can I stop having these visits? And it seems like everything's going well, but sometimes things can happen unexpectedly, and unless the tumor in the eye and the health of the eye and vision is being monitored, it's just important to check for these few things. And here's some of the things that we do, and I know that Dr. Gombos touched on what we do at the initial diagnosis, but many of these same tests are still performed afterwards. The examination, so looking at the eye, we get I would say that most of our information comes from this part. The ultrasound, and I have a little picture of an ultrasound off to the far side of the slide here. We use that to continue to monitor for response. And usually we want to be sure that there's no increase in growth. And there's some new tests. There's this test called OCT, or ocular coherence tomography. That's allowing us to look at the center of the vision and help us determine one of the side effects, which is radiation retinopathy. And this is one way we can monitor this. And certainly getting photographs and looking at the tumor. And I know that fluorescein angiography is, its use in diagnosis may be, it's certainly supportive, but a lot of doctors will continue to get an occasional angiogram because it can tell what's happening with the circulation of the rest of the eye. So the reason why we look so carefully is because if there's a chance to intervene, if you start to develop complications, there are certain treatments that can help. And probably in the last few years, we've had drugs that are very successful at treating people who have macular degeneration. We're finding that some of these drugs, and you may have heard of them, Avastin, this is the most commonly used drug to help treat radiation. It sometimes can help reverse some of the immediate effects of the radiation side effect. And certainly we look for signs that the eye might need laser treatment. Oftentimes the eye may develop a cataract as a secondary effect of the radiation, so we want to check for that in case you might benefit from having cataract surgery to help the vision. And certainly if there's blood in the eye that's been there for a while, it's possible that doing surgery to remove that might help. So these are some of the reasons why it's really important to keep looking and examining carefully even after the treatment. And many of you are probably very familiar with this. So what if the eye is removed? Sometimes we often may not see these patients back as frequently because they're obviously not going to have complications with the eye once it's removed. But it's important that people who have their eye removed continue to see their ocularist, the person who helped design and create the prosthesis, because there can be a buildup and things that irritate the eye socket. So you want to make sure that the prosthesis continues to be monitored. And certainly it's important to keep checking the uninvolved eye to make sure that that eye stays in the best health and has the best vision possible. And also it's a chance, again, to talk about what tests are you doing to monitor the cancer. And again, if there's new information that's coming up in the field, unless you're connected to a group like this, some patients don't really know what some of the new recommendations may be or any clinical trials if they should need them. So I'm going to touch a little bit on systemic surveillance, and this is just following the rest of the body after the eye has been treated. It's really important to convey to people that even though the eye has been treated, there's still a risk that the cancer can spread. And I try to bring this up at the very beginning and remind people that we can't just forget about it once the eye has been treated. We need to follow the body closely and make sure. And the question is, why? Because my eye's been treated. Why would the cancer come back? Because all my scans have been negative, so I don't understand why we need to keep looking. And the reason why, it's not entirely clear even to us why this is the case, but there's sort of emerging evidence now that there's likely microscopic tumor cells that have been released from this eye melanoma long before it was even diagnosed. So when it was just starting to be formed and it didn't have any symptoms, there may be some tumor cells that spread throughout the body and just sort of lay dormant. We don't really know, but this is sort of the theory that we accept most to help explain why people can get cancer so many years later in certain cases. And in general, when we're doing this screening, which is looking for metastasis or spread of the cancer outside of the eye, the liver, as was mentioned before, is the most common site of spread. So whatever test is done, it's really important that it includes the abdomen with looking at the liver. And the lung is a much less common site, but occasionally we do see this in the lung. But sometimes I have patients who their doctors have been getting MRIs of the brain and all sorts of things, and I encourage them not to pursue those tests because those are really low yield. We really want to focus on the abdomen. And so then the question is, well, you know, as we've heard, this field is emerging and changing, and even when I first started, there was a totally different approach to monitoring and treatment. And one of the extremes was there were some oncologists that were working with some of our patients who said, well, I don't think that you should bother with any type of screening because there are no good treatments. So I had a lot of patients that never had any screening, and their doctors felt there was no point. Well, the earlier that metastatic disease is diagnosed, the many more options are open. And when I first started in this field, I guess 8 or 9 years ago now, there were no treatments. No one would consider doing liver resection or anything surgical or focal. And now I see many patients that are doing very well several years after their metastatic disease has been detected. So the earlier that metastatic disease is detected, the more options there are. And the more on top of your whole situation you can be with more information that you have. However, I still think screening and looking for metastatic disease is very controversial. And there's really no agreed upon consensus as the best test and how often. But you know, I completely agree with what Dr. Gombos was saying, is that there's sort of the oncologist involved thinks about all the different aspects and then comes up with what test he or she thinks may be best suitable. And there's certainly a range that I see, but I'll just go over some of the tests. Usually it's a combination of a blood test and an imaging test, and I think this is sort of what most of us do, and the blood tests are looking at liver enzymes. Chest x-ray is something that we used to do a lot more in the past, but I think it's falling out of favor because it's not really focusing on the most important organ. There's liver ultrasound, which is a relatively non-invasive test. It doesn't have any radiation exposure associated with it. And then there's a CT scan of the abdomen. There's some radiation with that. There's MRI, which doesn't have any additional radiation, which has no radiation, I should say. And then there's the PET CT scan, which looks at the whole body, and there is probably more radiation associated with that. And you'll find that with all these possibilities of tests, there's a lot of difference in opinion. And you know, talking to some of my colleagues, a lot of us feel that an MRI that has no additional radiation exposure may be a good test to recommend for patients to have regular screening. And with the PET CT scan, I mean, this is sort of a probably relatively newer test compared to these other modalities that seems to be more and more popular in the field of oncology. There's some concern, especially in younger patients who have routine PET CT scans, that might be putting them at unnecessary radiation exposure risk. However, if there's something that your doctors find on your scan and they want to monitor you closely, I think it's very justified to have maybe a more detailed scan like that available. So those are some of the things that I wanted to touch on, and I'm sure many of you are familiar with this, but that's what I wanted to share with you today. Thank you. So I think at this time we'll be happy to answer questions and anything that anyone may have, and maybe I can sit here with Dr. Gombos here.
Yeah, so if you have a question, why don't you line up at one of the microphones, and we'll do questions that way. And if you have a problem getting up, then we'll bring one to you.
Oh, can you hear me? Okay, my quick question is, for anyone who's been getting regular abdominal and pelvic CT scans for, a long time, 14 years, has anyone, like if you went to your oncologist, has anyone ever said, okay, well, I want to now, since I'm going to be doing this for a while, can I switch to MRI? Just sort of start cutting down on radiation. Has anyone ever done that? Do doctors do that? Is that the done thing?
It's actually very timely that you asked this question, because I think you're sort of touching on a critical aspect that the physicians are also debating within the field. So you have to understand, and I can't emphasize this enough, when I talk to our doctors here, when we go to meetings, when we read the literature, there is no uniformity. There are really, and it also is so, it gets to a series of highly complex questions. How young is the patient when they started? What is the relative radiation exposure? As Dr. McCannel pointed out, a PET CT is different than a regular CT. It gets even more complicated because they're liver protocol CT as opposed to regular CT. And then the radiation risk is different for a male patient, for a female patient. And then you also want to, on top of that, add the relative risk of developing a melanoma versus, and the potential benefits of those scans. And on top of that, each scan is not the same scan in every institution. You're going to have different machines, different radiation exposure, different oncologists who are reading it. And the whole point is to try to also not have what we call false positives. Oh my God, there's something on the scan, turns out to be nothing, but now we put you through God knows how many biopsies, etc. So my approach to you, which I think is a very reasonable one, is everyone in this field is open to discussions with their patients. I interact every month. Our group in uveal melanoma meet. We meet about the research side of things. We meet about the clinical side of things, and we meet about patients who say, you know what, that patient that I saw last week brought up this question. Let's discuss it. And I think the best approach is to have a frank discussion with your oncologist and say, why are you choosing this modality? What are the risks and benefits? Do you think that in your institution this would be a good approach? And can we find a balance and a milieu that works with your needs and what they want? Your point is a valid one. Over a lifetime, there is some radiation exposure. We also need to mitigate this by the fact saying that you have a cancer, and so you're not the regular patient population. And so I can tell you that even 2 weeks ago, I and Dr. Patel, who you'll meet later today, met with our radiologists and had these exact questions at the most technical level. It's really not a simple, it's not like this test is better than that test and this radiation exposure is more than that. Dr. McCannel wrote a manuscript recently addressing this issue, and they're valid, they're very valid questions, but to suggest that there's one answer we're not there yet. And I would really encourage you to speak to the oncologist and say, why is it that you're doing this? And can we do that? And ultimately, the answer to your question is, yes, we have changed things when patients, in a thoughtful fashion, in a group fashion, said, we together are going to change this for you because this is unique to you. Because ultimately, medicine is about the patient. It's not about the doctor.
And can I just add one thing just to emphasize one point that Dr. Gombos just made about discussion in the physician community. We convened a meeting in New York, which you'll hear a little bit more about tomorrow, just getting people around a table to start hashing out some of these questions and talking about the issues that Dr. Gombos is pointing out. Like Dr. Gombos said, there aren't any easy answers, but we're hoping that as sort of an individual, or sort of unbiased umbrella, we can help bring people together to have these discussions, and advocate for patients and for physicians. Physicians want to know the same answers as well. So we're working on pushing these questions forward as well. Sorry.
I really agree 100% with what Dr. Gombos said. And it comes up frequently, or I might notice that, this person is getting a lot of PET CT scans, and I'll bring it up. If the patient isn't going to bring it up, I'll usually say, well, why don't you talk to Dr. So-and-so about switching? Because, especially I think in the last few years, there's been a lot of media attention to overdosing with radiation treatments, and, it's something to be concerned about. It's a very important topic, but I think that if you don't need to be having, say, one extreme, a full-body PET CT scan, then it's very valid to switch to something else. And, I would definitely bring it up with the next person you see, because I often write in letters, why don't we consider switching? Because, in our practice, we don't always have the same oncologist looking after patients. And oftentimes people have their local oncologist, and they're just looking for recommendations. So I think it's very valid to switch.
Yes.
Hi. My question is, in different groups and in topics and this and that, I have heard and read that the faster a tumor shrinks after the plaque treatment, is not a good sign? And the slower the shrinkage, the better?
I think that's, in general, that's correct. There is definitely literature that supports that the faster the response, the more aggressive the type of cells. But it's not a universal, if we don't divide people into a high or low risk based on that. It's just an observation.
Okay.
And so, we get the opposite as well. If the tumor size doesn't seem to change much, oftentimes patients get very worried. They say, I want this thing to shrink, but as long as it's not growing, I think you're in a good spot.
Well, I mean, I'll be 5 years, March 8th, treatment, and I'm actually still shrinking. And I went from like 6 3/4, and I'm below a 2 now. So I keep telling the doctor one day I'm going to walk in and it's going to be gone, so thank you.
It's very interesting. So one of the people who trained me was in doing uveal melanomas for 25 years, and that was an observation he would have, that patients who had very rapidly shrinking tumors would potentially metastasize. And so that was an observation in the context of not having great prognostic tests. One thing we've all learned from these sort of tests that we're now doing is we have a molecular test that we can look at that better stratifies patients. So while that may have been sort of an off-the-cuff perspective of many senior people in the field, we now have other things that are more predictable than just a generalized observation that may or may not be applicable to a specific patient. But it is certainly something that very senior people in the field who were around long before we ever did prognostication would be concerned about that. But you can imagine something that's rapidly growing may also be inclined to rapidly shrink.
Another question?
Good morning. Yeah, I have a question. I'm less than a year diagnosed with the rarest form of ocular melanoma. I have conjunctival melanoma. So I'm having a hard time getting a definitive answer from anybody as to what is the recommended follow-up scans for me. And I was initially denied a CT scan 5 times of my liver, and then I'm not clear if I understand correctly that the liver isn't really where we need to be looking for me personally. Do you have recommendations that maybe I can take back to my oncologist? So
as I started, that's probably why I opened up my talk the way I did, because this talk that we gave was primarily on uveal, and you already see that within the uveal community, there is no consensus. We're 10 steps behind in the conjunctival area, because although they use the term melanoma, they are cousins. They are not siblings. They are not the same disease. They spread by different mechanisms. The lymph nodes around the eye are a much more important component of this disease. You will generally find people make recommendations of scans around the head and the periocular area, very different. Dr. McCannel said I don't normally get scans of the brain, but the periocular structures for a conjunctival lesion are far more different. And also the stratification is very different. We don't have that sort of prognostic test that we do. We still base things on size, location, excision, all this sort of thing. So we would generally not routinely focus on the liver for a conjunctival tumor per se.
And would that be an MRI or a CT?
So again, and not only that, but ultrasound. And so, in our institution, periocular ultrasonography of the lymph nodes is a great thing, but it's very technician dependent. So once again, I think you're not going to find one approach. I think, again, people may go down the road of periocular imaging with echography or ultrasound. CT or MRI, you're going to see all those things, but you're not going to see liver-directed tests. And I think it's very important whenever you're in a community talking about ocular that you identify that you're dealing with conjunctival, which really is different and more rare than even this rare disease. There are things more rare than uveal melanoma.
And if I might chime in, you'll hear it in my talk.
This is Dr. Scott Woodman over here, for those of you who don't know him, a medical oncologist here at MD Anderson.
The genetic mutations in conjunctival melanoma
We have at least a couple of folks in the, I don't mean to call you out, but I know we have at least a couple of folks in the audience with conjunctival melanoma, so. That's right.
I have maybe a little more specific question about my case. I was found to have choroidal melanoma around Christmas time. My eye was removed on the 4th, and since then I've had a PET CT scan of my body and MRI in my head, brain scan. So my question is, the pathology on the tumor turned out to be a type 1B from the Decision DX test, and I've been underwhelmed with the competency of my oncologist at UT Southwestern. And so I've kind of fired the bunch I was working with. And so my question is, moving forward with the gene expression on my tumor being the way it is, one, what would be a recommendation if I was a patient in terms of the scans that I have? Would it be different between a type 1 and type 2? And then I guess the other thing would be, do you guys have any colleagues in the Dallas area that are competent?
Well, I think that you brought up something that Sarah just touched on, which is sort of using some of this is what we talked about at this meeting that a bunch of ophthalmic oncologists convened. And now with biopsy, prior to prognostic biopsy, we just sort of went by tumor size, and there really had the same recommendations for everybody, whether, because we just didn't know what your risk would be on a molecular level. But now that we have some indication, whether you're sort of lower risk or higher risk, I think that, again, there's going to be a range of opinion, and recommendations are going to be different. But I think that someone who has a lower risk, and I don't know if it's okay to say this, but I think that many of us might recommend a test twice a year, and this is sort of again a very controversial area. And if your PET CT scans have always been completely normal, and you being a very young person, it might be recommended to switch to a test that has less radiation exposure.
That's kind of what I was hoping to hear. I've had one scan because it's pretty fresh, and ultimately I'll be the one making the decision. So I was more concerned maybe what would be the upper limit of radiation exposure for a 35-year-old male in terms of the PET CT scans. For example, could I have 2 of those and maintain health indefinitely, or are we talking 1 a month would put me into radiation exposure? And I know that you can't give exact answers. I'm asking for your opinion. So,
I think one thing that's unique that we really should point out is that, and this may start to get a little bit more complicated, but when the tests for GEP were defined, they were initially defined as one.
Can you explain GEP?
Oh, sorry, the Castle test, the gene expression profiling. It was initially just written as you were either a class 1 or a class 2. And then it got a little bit more interesting, because then they took the class 1 and they made a 1A and a 1B. And why is that significant? Because the patients with class 2, their risk of spread is more upfront. Particularly within the first 3 years, we know that the risk is quite significant. What it suggests with the 1B is that risk is longer over a longer period of time.
and increases a little bit from what I've
Right, so it's
what they told me from Castle.
so what I think needs to happen with a young patient like yourself is, again, a discussion with the oncologist about how do we strategize long-term, because the 1Bs are thought over they don't have a huge risk, but their risk is different than the 1As. Long-term, how do we identify the tests and the appropriate screening that makes sense? And, again, our institution will have an answer, Dr. McCannel's institution will have an answer. There is no uniformity, but I do think you can have a discussion. I mean, we certainly know the radiation risk with all these tests. We certainly know how much radiation is being exposed. And we certainly can give some numbers, and Dr. McCannel has really nicely demonstrated that in a manuscript in the medical literature about what those numbers mean over 20, 30 years for a young man or woman. So I think a 1B is a unique scenario where you're going to have a one-on-one because your risk is long-term, probably longer term than other patients. And what are the appropriate tests? And the other thing is that 1Bs might be a sub-cohort that not only spread to the liver but to other areas. So it is again, we don't have 20, 30 years of these tests. We have probably good data for 6 or 7 years worth. So,
yeah, 1,800 is what she told me as to the patient population that has decision DX testing.
Right, and so again, those patients are also being monitored, throughout the country. So the point of this is that yes, I think there is a relative risk with any test that you do, and you are in control of monitoring things in concert with the oncologist, but I'm very hesitant for people to take away any generality. There is so
Sure.
many specifics to each thing, and I always worry, even in our meetings in medicine, that people try to come up with one answer. Sarah will tell you, when we met in New York, it would have been nice to package everything with one, this is the recommendation. Physicians really want to do the right thing, and we all come at it from a different perspective. And if you're passionate enough, you can imagine that 20 people in a room all believe that they're doing the right thing, and if they don't all agree, they're going to say, no, we have to do X, we have to do Y. So, but I do think a personalized approach makes sense, and you can find melanoma medical oncologists and ocular oncologists who have focused on this issue in every state in the country. And if you're not happy with however things are being associated, you can find people who are focused on that. You'll meet other oncologists here. You have the chairman and multiple members of melanoma medical oncology here at Anderson to at least use as a resource, and they know all their colleagues locally. And in each state, there are sort of people who are in the group, and I'm sure they can find someone for you locally who they can work with.
Thank you.
Can I build on this conversation very briefly? I'll do it from the microphone. I think this raises, I think there's a broader issue that was touched on by the very first part of the comment here. In a lot of areas of medicine, the approach to dealing with an issue is fairly clear. And you may have some variation within that approach, but it's fairly narrow. I know that in melanoma in general, and I think particularly in ocular melanoma, there's a lot of variation in what the right approach is. Do you do genetic testing? Do you not do genetic testing? If you do genetic testing, do you do the Castle approach or do you use some other approach? Do you do surveillance, and how do you do adjuvant therapy? And if so, what do you offer? And it seems to me that the answers are not yet clear. The data's not in on all of this. I mean, it's beginning maybe to get there, but it's not yet clear. So within the group of people who are really good at dealing with ocular melanoma, you have some fairly significant disagreement about approaches. But then there's another whole group of people, and it may not be a large group, but there are people out there who are really not good at ocular melanoma and are treating a few patients here and there. And I think from a patient perspective or a caregiver perspective, you want to make sure you're getting good care. And so it's confusing when you have people who are offering good care saying this and people are offering good care offering this. But frankly, you're getting good care either way. But what's really confusing is you've got one person saying this, one person saying this, and then somebody saying something that's completely out on left field. And from a patient side, it all looks the same. Now you've got three opinions. How do you know which one's really valid, which one's not valid, which two are valid, and which one's the outlier? All of this is a very long introduction to say, how can patients and caregivers be sure that they're being seen by somebody who knows what they're doing? And people who know what they're doing may vary in their opinions about what to do, but how can patients be sure they're being seen by somebody who knows what they're doing? I mean, short of going to one of you two, right? I mean, because we'd love for everybody to go to one, but how do you ask the right questions? How do you do the right kind of research that you can have confidence that, yeah, maybe not everybody would do it this way, but this is a really valid, legitimate, appropriate approach?
Yeah, I just think that's really hard because most of the patient who's diagnosed initially it's usually by their general ophthalmologist or maybe their retina specialist, and they get referred to somebody, and everything happens so quickly, and there's all this information that is terrible all at once, and you just want to get through it. And in the very beginning, it's just not the time when people are able to do a lot of thorough, careful research and figure it out. It seems it's often after the treatment's been done, and then people are, getting themselves together to figure out how they're going to manage this for the rest of their life, and then people start doing, have the ability to do more research and focus. But I just find it's very hard up front because, you're referred to the doctor, and when you get referred to a doctor, many don't question what it is. I think the tip-off is that it's a rare cancer, and some people, when they hear it's rare, that's when they're going to think, well, this isn't so common, maybe I'll just get another opinion, but most patients don't, and I don't know what your experience is, but my experience is that people go and they just can't, they don't have the tools to sort it out, and they don't know about the resources at all from the beginning, and they find this later. And so, there's a lot of things that might have been done up front, or maybe differences in treatment and approach, but I'm not sure myself how to make it so that someone who gets diagnosed with this can figure it out, except maybe having the website or information available. But many patients are not web savvy. They don't go to the internet for health concerns. So that's a real problem.
Even simple questions, in uveal melanoma, but in other fields as well, just asking how many patients like me have you treated before? How many other cases have you seen? And I think the other thing that I always think in medicine is that never being afraid to seek a second opinion. And, as a physician, I would say that if you see a physician who is threatened in any way by you saying you want a second physician, by saying you want to seek a second opinion, then they're not the physician you want to be working with. I think that as physicians, we all need to be open to that. And so I think that those are two pretty simple things that can help people, find where they need to be for care.
Yeah, second opinions are really good. I always recommend if someone's doubtful, the more information they can get up front to feel comfortable about it, the better. But, people are scared to ask. They feel that they're going to offend their doctor.
Right.
So.
I think, though, some of that is also generational. So I think we are of a generation that are comfortable with second opinions. Those of you who know me know I encourage people to get second opinions. I'm fine with that. I could just give you the perspective of my father, who is an 80-year-old ophthalmologist, who was of a different generation, where people didn't question. They sort of went to an expert and got their opinion. And I don't think anyone has to worry today about offending anyone. I think you are in control of your own care, and this tumor didn't happen yesterday, therefore you have tomorrow to think about how you approach things. Unfortunately, we're talking to the wrong cohort. We're talking to people who've already been through this process. I do think that getting second, third opinions are fine. Sometimes it confuses things because you're going to hear different opinions. But by and large, those people who are sort of focused and manage this disease you'll eventually get to the right hands with the right people asking the right things. A lot of the issues that are coming up now are sort of monitoring, serial imaging, those sort of issues. And I think eventually through the sort of question, back and forth, you will find the right opinion. Or you can get second opinion in some center that's sort of focusing on this issue, and then go back to your local community. People said you have to, we all are in sort of big medical centers, and people don't like coming to big medical centers. They hate the traffic, they hate flying, they hate all that. You can impart a lot of that knowledge from one visit with a series of experts and take it back to your community and make sure that that's being monitored and still get the appropriate care. And then you feel that you've also tapped into a different resource.
So we're now out of time. We're eating into the break. Would you mind taking your
I just want to
question
respond
offline?
to this real
Oh, okay.
quick. So I'm Mike Lescure. I'm the husband of Suzanne Lescure, who's had been battling conjunctival melanoma for 10 years. We started our journey. We started at UCSF in San Francisco, and we're from San Francisco area. Had some multiple doctors there. Our original doctor that she went to for many years as an ass, so we had that. But when we did is second opinions, like they were talking about, is the thing. The problem is you kind of need to get out of Dallas if you're not happy with what's going on there. You go to Philadelphia, you go to San Francisco, you go to UCLA, and go over, and it doesn't hurt to get the second opinions. But the problem with second opinions at that level, at a national level, is very expensive. So that's the problem. You know, if to respond to what you were asking, that's what you have to do. You really have to go to the other experts and get those cross opinions. So the doctors we had in San Francisco, once we got the cross opinions and got the letters going back and forth, you know, saved her life basically, because we've probably been to 10 different experts, you know, around the country. She's cancer free for 6 years now, so it's pretty good. Got in her lungs, and you know, this group, this is also a great resource for you. So all the people in here have gone through that journey already. So if you kind of stay with the group, and this is why this is good, because this is a good resource for you.
Thank you. And thank you, Dr. Gombos and Dr. McCannel. Really appreciate it. Just a couple points before we go away on break. So one, I just want to make sure that everyone has a folder, because we have some extra ones down here. I know we had a few people who didn't show up, but I just want to make sure everyone has a folder and agendas. And if you don't have one in front of you, please come up and get some up here. I also just want to take a minute, and I think they're not all in the room, but I just wanted to thank all the MD Anderson staff who have been so helpful, and Ricky sitting here in the corner who's working all the IT. Just want to thank you so much for all your help making this possible. We are really relying on you guys today. And then just a reminder, during the break, so when we come back, we're going to have systemic therapy panel in here, and we actually have an additional person who's going to be on the panel who's not on the agenda. So it's Dr. Sapna Patel, Dr. Patrick Wu, and then Dr. David Hong, who is from the Phase 1 clinical trials group here at MD Anderson. And then we also have a concurrent session, if you would prefer that. And then later on, we are going to be breaking into our small groups. And so I just want to make sure that during the break, if you haven't already signed up for one of the breakout sessions and want to participate, the sign-ups are on the front table. And I think those are the announcements for now. So we will come back here in about 12 minutes. Thank you.
About 12 minutes.
12 minutes exactly. I mean 12 minutes. Thank you. Oh, yeah, great, awesome. Picture of the town. Yes.
Easy trip for me. She came all the way from across the West Coast. But we did find that one week in Houston where the weather was sort of tolerable. Do
you know which doctor my husband was referring to?
Yes, I do.
Of course.
I'm not going to say it. But he's actually a very good clinician. And he's a good doctor. He really is. I understand.
I can just email you the PDF, because I think if you go to the journal website, there's all these fees when you try to access medical journals. But I have a PDF on my computer. I can either, maybe I can just put it on a USB stick. But it'd be nice to have that available. Sure, yeah. And I'll just email it to you, because it's sort of,
well,
it kind of went to
it's unfortunate that happened, but I would simply say that he's a very well-experienced clinician, and everyone always has the opportunity to sort of take their care however they'd like, but he is very well respected. He's been in the field for many years, and I'm sure while the interactions may not have been how you may have wanted them, he is a very good and very well experienced clinician.
There's one L.
And
I see more.
Yeah, and I'll just,
well, I don't know. I'm not here to sort of figure out how he makes those statements, but I do think that however it was with the bedside issues, he's a very experienced senior person in the field, and you should at least feel comfortable with that. Well, I'll leave it at that.
But the question I wanted to ask you is, you were saying that OM, conjunctival melanoma is not considered OM.
It's considered an ocular tumor, but so many of the people here actually have a uveal tumor, and people use those terms interchangeably, and they technically really aren't. And so I wanted to just let people know that there may be a cohort, I didn't know you were in the audience, but there may be a cohort that will say I have an ocular melanoma, but in fact they're really talking about either skin, cutaneous melanoma, or conjunctival melanoma, even though most of the people, most of the forums, and most of the questions are focusing about uveal. And they're not entirely interchangeable.
Yeah, besides the one that just asked the question, Josh asked,
Right.
So it's like we're very limited on Reddit or Facebook resources to find each other. I'm the only one who know about all of this. Of course,
Unfortunately, it does happen, and I have seen it as well. So, but you're very fortunate that you got good. It's a different disease. It really is. It's a cousin, not a sibling.
I thought it was a sibling, but I didn't think that
It does. Right. But it's wonderful. It looks great. It really looks great.
Thank you. Yeah, thank you guys.
Our pleasure.
For being here.
Mr. Ritchie. Well, she's organizing it, so she's going to speak.
it's at my home
It's
base.
a-
Yeah, so they'll be good. We'll get all of our oncology people. Oh, he is part of UCLA. Oh, he is. No. But we have like Rebus, who does a lot of cutaneous melanoma, but they also help us look after patients that have ocular melanoma. Sorry to take up so much of your time.
No,
that's over here.
Mr. Ritchie is the spouse of one of my patients here in Houston. How are you?
I went to a talk last week on effective diagnosing physician.
Okay. Where was that?
Here.
Okay. Okay.
The database is limited in the sense that but the single biggest factor
So you still think that physicians have a disproportionate? So what's the takeaway?
Well, I think it depends on the patient.
Right.
Some people have to do research.
Oh yeah. Absolutely. Well, my thought, and the interesting thing is people think they'll upset the physician, but I can tell you for my dad, if you got a second opinion, it hurt him personally. It really did. And to this day, he doesn't understand why I have no problem with it. He doesn't, because he's like, but they came to see you. They wanted your opinion. I said, yeah, but it's never really about me. And it isn't. So my only point was just that it is a different generation. And also the inclination of patients to get second opinions. I think some worry about that, but in the end, you can't worry about hurting someone's feelings. That should be not the primary focus. But you're absolutely correct. Other thing is some people don't want to keep looking. They've already been referred from maybe an optometrist to an ophthalmologist to a retina specialist to a cancer person. They may have already been down, and sometimes, as you know, we are the fifth or sixth person that's sort of finally willing to say those words, it's cancer.
Well, I've been sort of a
Yeah, by all means. But But they're worth bringing up. I don't think any of us ever, it's always good questioning things. Really, 20, 30 years ago, the standard approach was remove the eye, and people who did anything less to that were considered sort of, yeah. But you also have, I think, an ability to traverse the medical literature in a way that most patients don't. I mean, you're more savvy into getting a lot of manuscripts and reading them and reviewing them. I don't know everyone else is going to actually get the manuscript and review it and read it. I think you're more inclined to do that, which gives you a different informational. Yeah, thanks for coming. Well, let's just delete your thing. I
decided to hold off on presenting the last few bits because I think there's just so much, everyone has different recommendations and I think that sorry, go ahead.
No, I was just going to say thank you. And will you guys be able to stay around for lunch?
Yes, I can stay for
lunch.
lunch.
2 days. I'm just going to hang out
Great.
and be part of this.
Great.
Okay,
all right.
so I'm.
Where's the? Oh, here it is. Recycle. Right? That's me. And which one's yours?
Maybe this one, I think. Care one patient. Yeah.
Did Sapna just put hers on?
Yes.
So Sapna's is here. Okay, this is Dr. Ron.
Celebration of life. Right?
So we have.
Do you know Sapna? Have you met Sapna?
No, I'm not.
So, we're sort of blessed in having a lot of oncologists here. So, Scott is our sort of translational person, and he came to the last meeting. But Sapna is also, every time I have a new patient now, she does all the screening.
Yeah, that's really good.
Well, I didn't have that when I first came. I did my own screening.
I tried. It's
very hard.
Basically, it's just uphill battle with insurance companies.
It's very hard.
Okay.
But June of 1993 was the summer that I took off from medical school in my third year.
Okay. What is it?
The whole summer. So, 20 years. I was thinking that I was gonna send David an anniversary letter. It's
Okay.
happy anniversary letter.
Okay, and this you right here?
Yes, sir.
Okay, yes, sir.
What do I have to here?
Right
Tom was
there.
resident of Cornell. Tom was resident at Cornell, first year resident, and I was like, I'm getting
This is suggested now.
I was not getting trying to match and just trying to get into the field.
Right.
And I went to the first year.
Hi, man.
All right. It was in the beginning of residency, so they were giving DHL lectures to residents at Cornell. I'm like, can I just? I remember David was giving a lecture at the Harkness, and Tom and I got into the back of his Volvo and drove up to Harlem. It was, so that's my history of knowing Tom when he was a resident. That's a long time ago.
Yeah. Time is just sort of, it's funny, but I find that with more time, I just get better. I can hear, I just have dealt with so many things that slip away. I'm like listening to you and thinking, there really is, I tend to have I try to sort of, it's difficult. You can't just sort of, and now what,
All right.
go back and look at their lives. So there's some interesting discrepancies. So basically anything that's they're either most or they're last two. I'm not sure what to think.
So which is your take on the best test? Obviously, you're looking at both, but do you feel that one test is...
So I accept that this is a RNA-based independent test. So I'm just
We don't routinely do pathology, and we send it out around the FNAs. And if it's an eye, they don't know that information.
So I said, I mean, so it's already these tests are nothing, right? And I remember before I decided to sign on, I would have been a lot of misgivings, but this is what people want, and I don't want to deny anyone.
Are the misgivings
I remember going to the meeting at AAO, and there was a guy there who was a meeting press and I talked to Derek for a while, somebody and said, he showed me the numbers for 1A, it says, look, 1A, 98% of the time, the little table, like,
Yeah.
and he goes, because we can't put 100% down, this is database. That was because we can't put I just have so many.
We've had two cases with 1A. We haven't been tested that much. So you know, it's like anything else. It's a street fire.
Yeah, you can put all your money on it.
And we have started altering screening based on that. And that's still...
That came out of this report.
Well,
That's what I...
But samples. You see samples.
Yeah, sure.
Glad you're here.
Thank you for coming back in. I think we're going to try and get started here. This is always the most difficult part of any conference, is pulling people back together. By the way.
But I think you're talking first.
Yeah, we will yell out there. What? Okay. Okay, thank you all for coming back. You're all, I'm now preaching to the choir because who we need to get back are the people in the hallway. Okay. I think while people are trickling back in, we'll go ahead and get started. So I just first want to mention, and maybe some of the people out in the hallway are folks who prefer to participate in the concurrent session, but I just want to highlight that for those of you who, I'm on the wrong page of the agenda, who want to participate in the meditation and mindfulness, mind and body healing session, meet outside the doors right here, and that session is starting now as well. And for those of you who want to be here for the expert panel, systemic therapy for metastatic disease, that's going to be in here. So just so people, it's sort of like getting on a plane and finding out you're going to the wrong place. So I feel like a pilot. Okay. So for this panel, we are really honored to have 3 people, and one person is not on your agenda, which I really apologize for, but you can add him with a pen. We're very lucky to have 2 people from the melanoma department here at MD Anderson, and Dr. Hong from up here, Dr. Hong from the Phase 1 clinical trials group here at MD Anderson. So we're going to start with Dr. Sapna Patel, who's a medical oncologist here, and we'll be talking about targeted therapies, and we'll maybe touch on adjuvant trials as well a little bit. And then from there, we'll move to hearing from Dr. Patrick Wu, who you heard from a little bit this morning, who's the head of the melanoma oncology department. Is that the correct title? Here at MD Anderson, and he'll speak on immunotherapies for ocular melanoma. And then we'll end with Dr. Hong from the Phase 1 clinical trials group, and then we'll have time, plenty of time for Q&A at the end of the session as well. So thank you all.
All right, thank you, Sarah, and thank you to the Planning Committee for putting on such a great, important meeting. Is there a pointer on here? Is it here? Is it this guy?
So the problem is that you have 2 screens, so you might just want to use the mouse.
Gotcha, okay. This one here, oh no. Okay. All right, so I am just going to review the current clinical trials that we have for metastatic disease, and I can briefly mention here we have an adjuvant trial as well, but I didn't put on a comprehensive list of adjuvant trials. As you all know, there are no FDA-approved therapies for this disease, so there's no standard therapy. So most patients at some point will find their way onto a clinical trial. And similarly, when we think of skin melanoma, not too many of those treatments directly translate into melanoma of the eye. And that's, for several reasons, but we kind of hint on it here. It's because when we think of melanoma by site of the body, we start to see that they're quite different. So there's melanoma that arises on chronically damaged skin, so sun-damaged skin. But you can also get melanoma here on the bottoms of your hands and feet. You can get it in the nail bed. You can get it in your mucous membranes, or you can get it on skin that's not very chronically sun-damaged. And then the third group of melanoma is the melanoma of the eye, the uveal melanomas. So when we think about the common gene mutations in these different sites of melanoma, the first one that comes to mind is a BRAF gene mutation. And many patients, when they have metastatic uveal melanoma, some of their tissue gets sent for a BRAF mutation. And in fact, you may have a long conversation with, a doctor about there's a therapy and if you have the right gene and this and that. Well, here are the numbers. In general, chronic sun-damaged skin is where this mutation is most common. So we think somewhere around half of chronic sun-damaged skin, if not a little bit more, have a BRAF mutation. But very few much lesser numbers of the melanomas that occur on the hands and the feet and the mucous membranes, but it's still there to some degree. There are no mutations in BRAF in melanoma of the eye. And there's a path, in that same pathway, there's another common gene called NRAS, and they're usually mutually exclusive. You have one gene mutation or the other. Again, it's most common in general in the chronically sun-damaged skin. It's a little less common in these other types, but it's not at all present in melanoma of the eye. Another gene that we look at is a gene called c-KIT. Now this gene is actually rarely mutated in sun-damaged skin melanoma, but it's more commonly found in the other types of melanomas that occur on the hands and the feet, the nails, the mucous membranes. But again, this gene is not mutated in melanoma of the eye. And then we have GNAQ and GNA11. And these two genes are not mutated in the chronic sun-damaged skin melanoma. They're not mutated in the melanoma of the hands and the feet, the nail beds, the mucous membranes, but they're quite frequently mutated in melanoma that arises in the eye, in the uveal tract. And so about 80% of our uveal melanomas have these mutations. So just looking at this pattern alone, you can see why we can't necessarily translate therapy from skin melanoma all the way over to melanoma of the eye. Okay, this is a list of the current clinical trials, and this should have been included in your folder. And I'll walk you guys through these studies. So ipilimumab is a clinical trial that we have running here at MD Anderson, and we have it open for metastatic patients, and we also have it open for patients who are at high risk of metastatic disease based on certain factors. So this is where we're talking about people who are at risk of it coming back somewhere other than the eye. In the few cases where it comes back in the eye, it's a little more complicated. We're not totally sure if that also means you're at risk of it coming back somewhere else. What ipilimumab does, it's not chemotherapy, it's immune therapy. And so immune therapy in general, particularly with this drug, it aims to keep your T cells fully activated. And in your cancer-fighting immune system, T cells are your strongest weapon. So this drug is aiming to keep the T cells in their fully activated state. The next clinical trial on your list is Markibo. And Markibo is a clinical trial that's still available at several sites in the United States. It's been ongoing for several years, and it's a clinical trial of chemotherapy. It's a chemotherapy agent. It's in the center here, a chemotherapy core known as vincristine, and it's surrounded by cholesterol shell. And that cholesterol shell helps with the penetration of this chemotherapy into human tissue and the uptake into tumors. Okay, so the next trial on your list is vorinostat, and this is a class of drugs known as HDAC inhibitors. So this is not as straightforward as chemotherapy and immune therapy to describe. So I wanted to ask you guys a question. How many of you guys have an iPod or an iPhone or some gadget that has the earbuds? A lot of people, yeah. Okay, and so how many times when you're going to go work out or go for a run or something, walk the dog, and you go to reach into the drawer, you open the drawer and it looks like this? Yeah. Or it looks like this? Yeah. Or if you have more than one like I do, it's like this. It's like a tangled mess. So the best way, to kind of keep them organized is to wrap them around these spools. These are different kind of fun little iPod earbud holders, and you can wrap it around these spools that keep it organized. So in much the same way, our DNA is wrapped around spools, and these spools are proteins known as histones. And these, it's very tightly regulated, but the DNA is wrapped about 2.5 times around each spool, and then it's packaged in. And that's basically what makes up a chromosome. So what you see here is you have DNA tightly wound around the protein histones, and it's packed in very tightly. Well, this complex can be relaxed so that there's more space in between the spools. And that process is the addition of a molecule on the tips of the DNA. And that molecule is an acetyl molecule. So the protein or enzyme that does that adds the acetyl molecules to the ends of the DNA, is something called histone acetyltransferase. It's just another protein or enzyme in the body. And just like the body has a protein to put the acetyl molecules on, it has a mechanism to remove them from the DNA and tightly pack the spools again. And that protein, that process is called deacetylation, and that protein or enzyme is called histone deacetylase. So why do we even care if the DNA is tight or if it's loose? Well, when the DNA is loose like this, it allows in machinery to come in and then read the DNA. It reads down the DNA and essentially expresses the genes. But when your DNA is tightly packed like this, the machinery can't fit in there and it can't express certain genes. So the genes of interest in a situation like this are genes that help the body kill the cancer. So basically expressing cancer-fighting genes. Okay, and then to confuse things even more, so we have a group of drugs that basically puts the acetyl molecule back on the DNA. And instead of calling them acetylators, acetyltransferases, we call them HDAC inhibitors. So it's an HDAC inhibitor, which means it acetylates the DNA. So we just wanted to make sure it was very complex so that only doctors could understand it. So there are many different types of HDAC inhibitors out there, frankly. So vorinostat is one of the more common ones that you might have heard of, and it's FDA approved for the treatment of a pre-leukemia syndrome known as MDS. It's also approved for a lymphoma of the skin, and this is the clinical trial listed on your sheet that Dr. Richard Carvajal is running at Memorial Sloan Kettering. So vorinostat is very specific for cancer, but there are many, many HDAC inhibitors in study and in clinical practice. A lot more of those come in intravenous formulation. This vorinostat is nice because it happens to be a pill formulation. But there are non-cancer drugs that also have this function of HDAC inhibition. And one of the oldest drugs is valproic acid. So have you guys heard of valproic acid? Anybody? It was approved in 1978 for the treatment of epilepsy. And it's later since gained approval for migraine headaches and mood disorders. So it does not have an indication for cancer specifically. Now, why are we studying vorinostat, or why are we more interested in that formulation than something like valproic acid? It's really because the body makes many different types of histone. So you have a histone 1, 2, 2A, 2B, and vorinostat, or the ones that are studied in cancer, tend to be quite specific. So they tend to be really specific for one of those histones, whereas something like valproic acid is nonspecific, and it can acetylate or deacetylate inhibit multiple histone complexes. So it's the difference between being very specific for a type of histone and very non-specific. And when you're non-specific, particularly with regards to a drug, it means it could also target many other types of DNA and cells in your body, and then that's where side effects come from. So in general, valproic acid comes with more side effects than something like vorinostat. Okay, this is the clinical trial that's actually at the bottom of the list. This is STA 9090. And STA 9090 is a clinical trial using something called a heat shock protein inhibitor. So a heat shock protein is a chaperone protein, and chaperone proteins essentially bind inside the cells to other proteins to protect them from things like heat shock or other mechanisms that are trying to kill them. And so by chaperoning these proteins, it prevents them from being destroyed. So a heat shock protein inhibitor will actually inhibit the chaperone protein and then make this tumor protein more susceptible to the signal of destruction, death, etc. Okay, the remaining trials on the list towards the bottom are all essentially targeting different pathways in the body. And this is just scratching the surface of cellular cancer pathways that are being investigated. So the different types of pathways are pathways that look at things like how a tumor cell continues to grow. How does a tumor cell invade into other organs? How does a tumor cell grow its own blood vessel or regulate its own nutrition? Or how does a blood vessel start to regulate its own expression of genes? So there are many of these different pathways that we're studying, and some of the clinical trials that you have listed address this. There's the AZD6244 study, and that's also being run out at Memorial Sloan Kettering, and that's a drug that inhibits a pathway that we think is important for tumor growth. So it's trying to stop or at least slow down that pathway. The next study on the list is a study of pasireotide with RAD001. This is a clinical trial that's looking to investigate two different pathways. So pasireotide is important in the insulin-like pathway. Insulin-like pathways are different than normal insulin and glucose metabolism. That's why they're insulin-like. But they are important in normal tissue development, skeletal development, and tumor growth. And so pasireotide helps to break that insulin-like pathway. And RAD001 works in another pathway here that would help to regulate kind of tumor survival and immortality, if you will. Last year at MD Anderson, we finished a clinical trial also looking at the insulin-like pathway, and we used a little different molecule that targeted this type 1 receptor. And with the help of Dr. Sato and Thomas Jefferson University, we were able to finish that study. So now we will have two clinical trials looking at the insulin-like pathway for this disease to see if it's important. And then the last study that's there is the PKC study, AEB071. And this helps, this is trying to break the pathway. PKC actually has multiple roles, as many proteins do in these pathways. They can play multiple roles or connect to multiple pathways. PKC is important in things like keeping cells immortal or preventing them from dying, and then also for growing cells. And so by blocking that, we hope that it will decrease the cell cycle or the proliferation and also make them more susceptible to death. So, as I mentioned, that's just a few of the pathways, but many, many more pathways still need to be investigated and studied for this disease. And then this is just a very famous slide I wanted to show you guys. It's from Drs. Hanahan and Weinberg, where they describe essentially the new emerging hallmarks of cancer. And they describe various mechanisms that cancers use to basically stay immortal and survive. And so some of that is just using growth signaling. It's also blocking the negative growth signals or the growth suppressors. These cancers are very smart. This is all cancer in general, but they tend to sneak past the immune system. They also like to stay immortal. So they try to avoid programmed death, or just like, they've reached the end of their life, they try to avoid that and stay immature and immortal. They also promote inflammation. Most cancer cells, part of their aggressiveness is because they like to learn how to dig deep and spread to other organs. Tumors can grow their own blood vessels. They can induce damage to DNA and make further gene mutations. Again, they can avoid cell death, and then they can deregulate energetics of the body so that, important nutrition and different energy molecules are directed away from your normal tissue and towards the tumor tissue. And so all of these outer boxes kind of describe mechanisms by which we're using to block these maneuvers. And as you see here, we're focusing certainly on immune activating targets, or even just keeping your immune system in the activated state in order to avoid these cancer cells from sneaking past the immune system. Okay, so just to recap the list, ipilimumab is the immune therapy looking to keep your T cells in their activated state. It's for metastatic disease. It's also for patients who are high risk based on certain criteria, who we think are at risk of this disease coming back distally. Marquibo is chemotherapy. It's available at a few places in the United States. It's chemotherapy in a cholesterol shell that will hopefully help it to be taken up by the tumor cells. Vorinostat is that HDAC inhibitor, so it helps to keep the spools a little bit more open so that genes can be expressed that will help to kill the tumor. EZD6244 is a MEK inhibitor that's trying to block a growth pathway in tumors. Pasriatide is an insulin-like pathway inhibitor, and RAD001 is an inhibitor of the PI3 kinase or survival pathway. AEB071 is a PKC inhibitor that will help to promote cell death and decrease the growth of cells. And then STA9090 is that heat shock protein inhibitor, and that's the one that will allow tumor cells to be unchaperoned and then more susceptible to things like heat shock or other types of cell death. So I just described to you a lot of different machinery that we use, and we need to keep investigating, certainly in this disease, and running clinical trials. There is, as I kind of heard from this morning's talk, you got the understanding that there's not one right answer in terms of how to treat this disease or how to follow this disease. And it's the same. We don't have one right piece of machinery that we know is the answer. So we're investigating a lot of different ones. And as is the case for a lot of cancers, we'll likely find that there's different types of equipment we can use for this disease, hopefully not just one right answer. And then finally, I just wanted to express my gratitude to all of you patients in the audience. You humble me with your bravery and your fortitude in clinic every day, and I thank you for allowing us to continue this commitment to the war on cancer. Thanks. And now Dr. Patrick Hu will give us an update on some immunotherapy for uveal melanoma.
Thanks, Sam. That was a lovely summary. And in addition, now I know how to keep my earbuds from getting tangled. It's a major problem. So, very happy to talk to you about the immune system. You heard a nice summary of ways we're trying to block specific pathways and light switches that turn on and off the cancers. We're also trying to stimulate the body's immune system against cancer. We all have immune systems, and they keep us alive every day. Anyone get the flu lately? Yeah, so some people have, and you're here to tell about it because your immune system came to the rescue and killed all those virally infected cells and kept you alive. And that's the same thing we're trying to do with the body's immune system now, targeted against different cancers, including ocular melanoma. So as everyone knows, ocular melanoma is an issue because it spreads to many parts of the body. Oftentimes the liver, but it can also go to other places as well. And so therefore we need treatments that go throughout the body. Some of those treatments are IV medications that can go throughout the body. Some are pills that can go throughout the body. But one approach with the immune system is to stimulate your immune cells, and they travel throughout the body and really know how to get on and off the exit ramps of our blood vessels to try to get to the cancers. And that's a way that can treat throughout the whole body is by stimulating the immune system. So in many of these instances, we'll use cutaneous melanoma as a model system because it's already starting to work in cutaneous melanoma, but we think these principles can go out to and be utilized for ocular melanoma as well as breast cancer, colon cancer. We really feel that these principles are going to be true because it's the same immune system, and we're going to be able to activate that in many kinds of different cancers. The whole basis for this is to kill the tumor cell. Now these immune cells, the most important one is called the cytotoxic T lymphocyte, or CTL. It's a kind of immune cell that recognizes, it was in our bodies to recognize virally infected cells, but it can also recognize tumor cells. It's, if you think about a baseball, it's like the batter is the T cell, the ball is the tumor, and it bats the ball, unless you're with the Astros, in which case you probably miss. But for the most part, the T cells will kill the tumor cells. And so this is just under the microscope, you can view this. This is over a period of hours, actually. The T cell recognizes the tumor and then secretes enzymes to poke holes into the tumor cell. and the tumor cell just implodes. And then that immune cell can truck over to the next tumor cell and secrete enzymes there, and once it touches it, we call that the kiss of death. It touches and then it secretes the enzymes, and then it can kill the tumor cell. So any time you hear about a cancer vaccine, a T-cell therapy, a cytokine, ipilimumab, the goal is always the same: to really fortify these immune cells, allow them to secrete enzymes to poke holes in the tumor so that the tumors die. And large masses of tumor can go away with that approach. So a few years ago, while I was still at the NCI, we innovated a method to try to grow the immune cells in the tumor itself. So in most tumors, your immune system's already trying to work. It's trying to kill that tumor, but obviously not doing a good enough job because the tumor is growing. So we've learned through the years to take those immune cells, take them out into the lab, and try to grow those cells to large numbers and give them back. We've started with cutaneous melanoma, but we're starting to move to ocular melanoma, to colon cancer, to lung cancer. We've grown immune cells, for example, from 19 colon cancers now. And so I think it's going to be a principle that's going to be true for many different kinds of cancers. I went through the records, and we found 4 patients that we tried to grow with ocular melanoma immune cells. Sometimes we can grow them, sometimes we can't. We were able to grow the cells on 2 of those patients. And in one of those patients, it was very clear that the MART1 antigen was being recognized, so we could even characterize what was being recognized. So we think we can grow these cells in some patients with ocular melanoma, but we certainly need to do a better job. 2 of 4 isn't good enough. We have methods now, we hope, to add other antibodies to really increase that number, that we can grow those immune cells so that we can then give them back as therapy. We grow them now in the lab to billions, and then give them back along with interleukin-2, the growth factor. And it's worked really well in some patients. This is, for example, one of our patients who was in high school with a disease that went to the brain and into the lungs, and we were able to treat him. It's now been it's been 5 years, and he's done just fine and is in college at Georgia right now. So this can have long-lasting effects, and that's because the immune cells stay in the body, can live in the body for a long time, years and years. And so we hope that we can get durable responses from that. Here's another patient of ours who had just come out of college and had a big tumor here that decreased, and this is a CAT scan with the tumor in the belly that shrank away, and tumors in the lung that also decreased. And so that also has been a very durable response lasting years. And sometimes we've even seen tumor that's gone to the brain shrink from this therapy. This is a brain metastasis. And finally, we've seen very durable responses in some patients. Here's a patient. This is in the pelvis. This is a CAT scan, so it's a cut through the pelvic bones. And you can see the lymph nodes here that were big and then over time shrank down, and now the patient's doing well. It's been over 3 years. So we know this can work. This kind of therapy can work. What we need to do now is to treat more patients with, to try to grow immune cells on more patients with ocular melanoma and move this kind of principle into ocular melanoma. A little bit more challenging because you have to do surgery to remove the tumor. Oftentimes the tumor is in the liver, so it would require a surgery to remove one of the tumors in the liver in order to grow. Sometimes that melanoma, ocular melanoma, will go to lungs, and so in the samples that we've done, 3 of the 4 that we try to grow were from the lung, actually, and the 4th one was from a subcutaneous lesion on the thigh. So we have other ways to possibly grow tumor, but it may take a little more extensive surgery to try to grow this and bring this kind of therapy into ocular melanoma. But our protocol is totally open to ocular melanoma. We didn't specify cutaneous or ocular, so we will, if anyone is eligible and wants to try that, and has a tumor that's accessible, we will attempt to grow T cells in those patients. Another way, Dr. Patel mentioned already, to try to stimulate the immune system is to take the brakes off the immune cells. So if you think about these cytotoxic T cells as tanks that can kill the tumors, most of them have their brakes on, and that's because these immune cells are very powerful. So if they were just going around our body releasing their ammunition, we would have a lot of toxicity, autoimmune toxicity. So that's why these immune cells always have their brake on, and these antibodies that one of them, Dr. Patel described, just take the brakes off the immune cells so that they can then kill the tumor with reckless abandon. And so the ipilimumab story has been a wonderful story. Here's a patient of mine who, we've been treating patients with ipilimumab now for over 10 years, and some of the patients over 10 years ago treated are still doing fine. So that shows that the immune system can have a very durable response in some patients. And this patient had melanoma for 15 years. He is over 70 years old now, and we gave him IPI about 5 years ago, and he's just done well. He's free of disease, just coming back for scans, and that's it. He likes to have his picture shown. I promised I'd make him famous. That's why every opportunity I get. Yeah. So ipilimumab has been tried in ocular melanoma. 13 patients from a study from Europe were tested, and 2 of those patients had stable disease, meaning the tumors were arrested, it looks like, and that lasted 9 months or over 9 months in the second patient. And another study, 5 patients report from the United Kingdom. 2 patients seem to have stable disease of 11 months and 15 months. So that's a start, and hopefully with Dr. Patel's trial we can get a lot more experience with ipilimumab in both the setting where we're trying to prevent the recurrence as well as we're trying to directly treat patients with active disease. And there's also many other antibodies coming along, like this antibody called anti-PD-1, which we think is even more effective and less toxic. And here's a study in cutaneous melanoma where you can see the vast majority of patients had disease either stay stable or shrink down. This is each tumor in each individual patient, including some very large lesions. The response rate's been extremely high and a very non-toxic therapy. And here's another patient of mine who had a similar kind of therapy with disease in the belly, behind the kidneys, and here is in the belly by the psoas muscle. And in that setting, all of his disease shrank away, and he's doing great over 3 years later. He was just flying back and forth for the therapy, but in the meantime, he went to Europe, he went on vacation everywhere. These therapies are much less toxic than they used to be too, the new generation therapies. And Jim Allison, who recently joined us, now has data that combining 2 of those antibodies, anti-PD-1 and anti-CTLA-4 together, those 2 antibodies, if we combine them, the effects are even greater. And now there's a trial going on where we're combining those antibodies. Now, there's no reason to think that ocular melanoma is not able to stimulate the immune system. The studies that have been done so far show that they do have antigens in them. That's how immune system cells recognize tumors. It's by antigens. They do have antigens in them that the immune system can recognize. So 2 of the major antigens that we've studied are called MART1 and GP100. We've studied it extensively in cutaneous melanoma, but these are ocular melanomas from an old paper that was studied, and in some of those patients the MART1 antigen was on, but in others the GP100 antigen was expressed. And so I think the antigens are going to be there. We haven't done extensive studies yet with ocular melanoma and immunotherapy, but I don't see any reason scientifically why ocular melanoma will not respond to immune manipulation. So I think with ipilimumab, anti-PD-1, TIL therapy, vaccines, we can really try to, we need to try to move that together to try to move that field forward. The other thing we need to do is to combine immunotherapies with targeted therapies. So targeted therapies are the therapies that Dr. Patel described, and you'll hear more from Dr. Hong. The response rates can be there, but they're often not so durable. For example, the MEK inhibitor for GNAQ or GNA11 positive ocular melanoma. There's some patients have responded, but not. It hasn't been so durable for a lot of those patients. But the immunotherapy in general, when it does work, it can work for a very, very long time. So we're hoping that if we can combine targeted therapy with immunotherapy, we can get even better therapy where a lot of people respond for a very long time. And that's one of our goals. We can't just put them together, though, because sometimes the targeted therapy will kill your immune cells, and so we've got to really be careful and figure out exactly the order to put them together and how to do that. We're starting to do that in our mouse models, and this is an experiment that we just did, and I got the results last week from one of our mouse models. And in that study, we're adding some immunotherapy to the MEK inhibitor. So if you give the MEK inhibitor to a mouse who has a tumor, and then you add an antibody, this is called anti-OX40, as opposed to ipilimumab, it actually puts the gas pedal down on the immune system. And so if you combine the MEK inhibitor plus the anti-OX40, you get even a better immune response and anti-tumor response as seen by how big the tumor is in the mouse. And so we think that this is really the future when we take the MEK inhibitor and combine it with antibodies to take targeted therapy plus immunotherapy in a rational way and put them together. We really have great hope for that kind of approach. We actually have a deal with GlaxoSmithKline to actually make this antibody for human use. So hopefully in the next year or two, we will actually have that antibody for clinical trials here at MD Anderson. And then we can freely, if we own the antibody or have it in collaboration with a specific company, we can then freely combine it much easier than if we were just trying to get the antibody from another company. So we're excited about this kind of approach to put the targeted therapies together with the immunotherapies. And it's interesting that we're concurrent with meditation and mindfulness sessions because there's also other studies in mouse models that have shown that stress is not a good thing and that anything to reduce stress actually, there are actually ways to stress out the mouse experimentally. And if you do that, the tumors always grow faster. So anything, I think that, and there have been human studies that have been done that show that your immune system is stronger when you're less stressed. We've had studies in our immune monitoring core with Lorenzo Cohen that have shown that active expressive writing and other things like that will actually allow you to have cells that can kill tumors better. And so that's, it was actually very surprising to me when I saw those results, but I do believe it now that anything you can do on the mindfulness side will help your immune system. And we, as I said before, we really appreciate everyone being here. And I want to echo what Tim said earlier and what Sarah has said about research. We often have many exciting things in the lab that, like what this MEK experiment. But we have ways to treat patients, but bringing what we have in the lab to the patients, it's very tough. It's a tenuous little area of the bridge. It's tough to get funding to do that. It's tough to do those experiments. And so I think with everyone's support of the MRF, with the CURE-OM of MD Anderson, we can really try to make this little bridge between the lab and the clinic into a superhighway, which is what we need to do, what we can do, and that's why I'm very optimistic if we can bring these concepts from the lab to the clinic quickly, we can really take care of this issue in the near future around the corner. I do sense it's around the corner. It's like all the data, as Tim was saying, is like an iceberg. You know, most of it's underground. There's a lot going on right now, and it hasn't hit the surface yet, but it's about to. And once it does, it can be very rapid. So we're very optimistic about this. So thanks a lot for your time today. Now, Dr. David Hong is now going to talk. He's a very talented investigator in our targeted therapy phase 1 group, and he is now going to talk to you about the many trials that they have available, and we always work in close collaboration with his group to try to get patients what they need.
Thanks again for inviting me, Dr. Hu and Zednov, to this talk. I had a chance to meet some of you all, especially Sarah, and hear some of the stories that you've had, and I'm sure there are many other inspiring and stories here. I'm not a melanoma expert or a uveal melanoma expert or even specifically a specific cancer expert of any kind. If anything, I'm more of a drug expert. I know about specific drugs and how to hopefully develop those drugs, particularly in the early setting. And I titled my talk, The Good, the Bad, the Ugly, because every Saturday around this time, my dad and I would watch these spaghetti westerns. We were big fans of Clint Eastwood. And so how I want to frame this talk is I want to kind of give you guys an idea of what is going on in drug development in cancer, because there's a lot of incredible and good things going on, but there are also some hurdles and some things that we need your help with in overcoming some of these hurdles to hopefully move new drugs into patients quicker and sooner. And then I'm going to talk a little bit about what exactly phase 1 trials are, what we do in our department, and specifically some of the studies that may be relevant to uveal melanoma cancer patients. So, as you all know, and you guys are probably aware if you're a caregiver or a cancer patient, cancer is now going to become the most highest cause of mortality, not only here in the Western world or in the United States, but probably it is, I think in 2012, has now become the highest cause of mortality in the world, higher than AIDS, higher than even malaria and other infectious diseases. So this disease is something that we all kind of have a vested interest in. About every 57 seconds, another American dies of cancer, and all of us are going to be affected by this, whether it's uveal melanoma or other types of cancers. About half of males are going to at some point come down with some type of cancer, and a third of women are going to, and about 1 in 3 of us will actually die from cancer at some point. So, you know, the first drugs for cancer were actually derived from chemical warfare. And it's a very interesting story. I'm not going to go into it in detail today, but over the last 20 or 30 years, we've really started to understand the molecular underpinnings of cancer. And that has really opened up, as Dr. Hu and Sebna have shared with you all about all these new molecular underpinnings of uveal melanoma. We're starting to understand that across all these different types of cancers. So as Dr. Hu had mentioned, it is this iceberg that we think is starting to emerge, and all that information is slowly both slowly and quickly entering into the clinic. So there are all these new directions in cancer. Some of these have already been shared, but I think one of the things what's really encouraging is that these cytotoxic chemotherapies in the past that oftentimes would not work, we're now starting to see these new molecular targeted therapies and immunotherapies that are starting to work. And what is really kind of pushing this forward is this idea and notion of genomic cancer, genomic medicine, and personalized cancer therapy. And the idea of personalized cancer therapy is that each of us, even though you may have a uveal melanoma, that you as a patient may have a unique molecular phenotype from some other patient that has a uveal melanoma. And so the idea is to be able to, at some point, really characterize each of your tumors to figure out which drugs you will benefit from, but also figure out which drugs you may not benefit from, may actually have cytotoxic, toxic effects from. And we're starting to do that. We're starting to have early success doing this, and I'm going to show you some data on this. But this is starting to snowball, and this is going to become more and more not only going to transform medicine, cancer medicine, but this will literally transform all of medicine. But there are some unfortunate hurdles that are in the way of trying to transform this care, and part of it has to do with trying to translate what our basic scientists, what Dr. Woodman, for example, will share with you later this afternoon, into the clinic. And a lot of that is just, unfortunately, man-made, and that is, I don't know if you guys ever seen this picture. How many of you are from Houston? I think this was a picture from Hurricane Ike. I remember when Hurricane Ike came here, we drove from our home from Meyerland to Jersey Village, which is probably, if there was no traffic, would take about 30 minutes. It took us 12 hours to get there on this ride, right? And so that's kind of the thought that unfortunately a lot of, I think there's a lot of regulation involved in clinical trial research for good reason to some extent, but also for a number of reasons it's often causing kind of a regulatory traffic jam. There are multiple agencies that are involved in drug development, the FDA, the NCI, HIPAA, CLIA, et cetera, and everybody has a hand in this, and unfortunately because of that, you have a lot of cars on the road and cause drug development to slow down. And this obviously leads to cost, delays, frustrations, et cetera. The average time to a drug to be developed from phase 1 trials, entering a phase 1 trial, to national approval is at this time around 9 years. From the time that a drug is actually identified preclinically, it takes another 7 years to get actually into the clinic. So a total average time of about 16 years. And many of you guys agree with me that that is way too long, right? And we are trying to do our best to try to shorten those timelines. I think the best way to shorten these timelines is to develop drugs that actually work much better and have dramatic effects, because the FDA is then prompted to move these developments along sooner than later. There are other problems with the system, and some people argue that the grant research system, one, there's a lack of funding, but it also incentivizes research that isn't really trying to break boundaries and trying to bring about cures. Some people also note that really the fact that cancer patients are actually not, especially adult cancer patients, are not involved in clinical trials. That's actually a very big problem, less so here at MD Anderson, but across the country. Many trials go incompleted or are not able to complete because patients, for whatever reason, many different reasons, are not able to enroll in clinical trials or are wanting to enroll in clinical trials. And so the fastest way for us to make progress in the clinic and eventually get these drugs approved is to get clinical trials up and running and get patients involved. And if there's anything you could do to be a part of that, if you're a uveal melanoma patient, is to actually try to get involved in a clinical trial. And there are some people would argue also ethical debates about how these clinical trials are designed. I don't know if you read this article. This was in 2010. It was Amy Harmon. This is a trial of vemurafenib, which is this new wonder drug that has been developed in cutaneous melanoma patients who have BRAF inhibitor studies. And unfortunately, the story of two twin brothers who both had melanoma, because it was a randomized trial, one of the brothers got the drug and the other one didn't. Despite the fact that in earlier phase 2 studies, this drug clearly had shown evidence of efficacy, the FDA had demanded a randomized phase 3 study. So there are a lot of debates about how we should design these trials as we move forward. Okay, so what do I do? So as I shared with you, I'm not a melanoma expert. I'm not a uveal melanoma expert. I'm not really a tumor expert of any kind. I'm more of an expert, if anything, and classes of drugs and how to design some of these early clinical trials. Our mission in our department is really to translate some of these lab discoveries that Dr. Woodman and Dr. Hu and some others, scientists, discover in the clinic and try to translate them into really hypothesis-driven clinical trials, early clinical trials. And our program actually began not too long ago, in 2004. Our chairman, Dr. Rizal Kurzrock, initiated a phase 1 program. I actually was employee number 3. I joined right after my fellowship here. And since then, we've grown to become a department, and we are now the largest phase 1 clinical trials program in the world. We have about 127 ongoing phase 1 clinical trials here. Our treatments are not disease-based. Most phase 1 trials, and let me step back here again, the FDA requires a 3-step process in order to get a drug approved. There is what's called a phase 1 clinical trial, which is the earliest of those clinical trials, and then usually a phase 2 trial in a specific tumor type, and then onto what's called a phase 3 registration trial, which tested in a much larger population. Phase 3 trials are oftentimes randomized studies, as I shared with you before, and they're usually randomized to standard of care. And again, it's in one tumor type. And if those patients, after following for a period of time, we find that those patients are appearing to do better on new drugs versus old, usually they go to the company will go to the FDA and say, can you approve this drug? Phase 2 studies are smaller studies. They're often done in academic institutions like MD Anderson. Again, in one tumor type, usually everybody gets the drug. They rarely do randomizations. And those patients then, if there's suggestion that they're having much better outcomes than historical records, famous doctors like Dr. Hu will get done with other famous doctors, the drug company and the FDA make a decision if they'll invest the time, money, and the number of patients to the larger phase 3. Phase 1 studies are truly the first in human studies that have transitioned from the animal models to humans. And the primary purpose of phase 1 studies is really to figure out what is the safest dose in human beings. Because we have some ideas from the dogs and the monkeys, but we could cure as many dogs and monkeys in the world, it wouldn't matter. What we want to do is we want to cure human beings. However, that's not the only purpose of these phase 1 studies. Unfortunately, the animal models oftentimes don't predict which patients and which tumor types may actually respond to these drugs. So the second and equally important purpose of phase 1 studies is to figure out which patients may actually benefit. So again, we often do these new first-in-human molecules. We do trials and combinations of oftentimes experimental drugs with drugs that are already approved. And we also do, which is to some interest of, for many of you all here, delivery and routes of delivery specifically to the liver. So again, one of the examples, I'll give you a perfect example of one of the drugs that some of these drugs that have been approved through that have gone through our group, and this notion of area of targeted therapy. There's a very rare type of lymphoma called Castleman's disease, which from the literature, people had known for a long time that was driven by a cytokine called IL-6. And we were able to actually get a trial in our clinic called CNT-0328, and we knew that this was an IL-6 antibody that would inhibit IL-6. And so given that and given the information we knew from the preclinical scientists, we went ahead and started to enroll patients with Castleman disease. And we've found a remarkable effect of these drugs. 12 out of 14 patients with Castleman's disease went on to have either partial responses or complete responses. This drug is now in a phase 3 registration study. My understanding is the interim analysis suggests that it's having significant benefit and will likely be approved in the next couple of months. So we know that if we can identify the target, if we can figure out how these tumors may be driven, that the right drug, matching the right person and the right drug may be of real benefit. Another example of this was a drug called cabozantinib that was recently approved in also in a rare thyroid cancer called medullary thyroid cancer that are driven by RET mutations. And so we recognized also that this drug also inhibited RET, and when we tried putting some patients with medullary thyroid cancer on, we had some of these dramatic responses. And this led to a phase 3 registration trial which just was completed less than a year ago and has led to the approval of this drug in this rare disease, which essentially had no known therapy prior to this and had known chemotherapy prior to this. So this is possible. We have an ongoing kind of protocol called PREDICT by Dr. Leon Saberto, who's a colleague of mine, that we've been looking at patients who come into our clinic, and we try to molecular profile our patients. Increasingly, this is something that we're doing now with in the melanoma group. I know everybody is now being at least analyzed for 46 genes. We have also other genetic molecular platforms that we're doing in our clinic that looks at over 200 genes. And we're trying to see if any of these patients who we are able to find the genetic match for and then match them to a clinical trial if they have benefit. And clearly they do seem to have benefit. Patients who are matched, even in these very heavily pretreated patient populations, most of the patients I see are patients who've failed all known therapies. They have a 23 to 27% response rate compared to a typical 4% response rate in patients who are not matched. And their survival and their overall time on the study is definitely improved. Our experience with uveal melanoma is limited. Many of you, we see some of these patients, but again, as you all are aware, uveal melanoma is a very rare cancer. We have put several patients on a recent study, this MEK inhibitor trabetinib, which Dr. Hu mentioned. And this is the results of a phase 1 trial that was recently published in Lancet Oncology. As you can see, the bars represent whether or not the patient's tumors increased or decreased. If you see a bar fall below the line, that means that the tumors have decreased. We did not see a huge amount of activity with the MEK inhibitor, but you have to take this with somewhat of a grain of salt. Part of this may be, again, the fact that most of our patients are very heavily pretreated. I was just talking with Dr. Woodman, and his suggestion is that there are some suggestions that patients who have not been treated with chemotherapy may be much more amenable through this MEK inhibitor, which targets this GNAC and G11 mutation, GNA11 mutation. Okay, so these are some of the ongoing studies that are probably relevant to you all in the context of uveal melanoma. CMET, as you all are aware, uveal melanoma, for whatever reason, metastasized to the liver more than anywhere else. And it turns out there is a ligand called hepatic growth factor, and CMET, the CMET tyrosine kinase is the receptor that binds to that. There are suggestions that perhaps the reason why uveal melanoma patients metastasize to the liver is because they have very high expressions of either CMET or HGF. And so we have several inhibitors of CMET that are being tested in phase 1. I will tell you my drug specifically, I'm the PI on the AMG 337 drug. We've had some dramatic responses, not necessarily in uveal melanoma, but in tumors that we know that have CMET elevation, CMET amplification, for example, esophageal and gastric. We have one patient who went into complete response and has been in complete response now for almost a year and a half. We have a number of other studies that are looking at angiogenesis, and we have a number of other studies that are looking at combinations of these targeted pathways, including RAF and CMET. And again, we do have what's called a regional therapy program, primarily, again, Dr. Simberdu, who is a colleague of mine, runs this regional therapy program where we are trying to deliver chemotherapies that have never been tested directly to the liver. For example, oxaliplatin and irinotecan, which are traditional chemotherapies. And lastly, we have a very small portfolio of immunotherapies, which I'm trying to develop with Dr. Hu and some other immunotherapy experts here. One is this combination of ipilimumab and imatinib, which is a c-KIT inhibitor. So that is kind of the portfolio of drugs that we have in the clinic that may be relevant to uveal melanoma patients in the clinic. I want to share that it's an exciting time for oncologists, and I know many of you guys have persevered through a lot. And I want to end this message with this notion that there is hope. In fact, I think there's a lot of hope. As Dr. Hu said, we are at the tip of the iceberg of these new therapies that are emerging that may eventually lead to cures. I want to thank my department. We have a great department, and unfortunately, our chair, Dr. Kurzrock, who sits there in the middle, has just recently left to become the cancer director at UC Morrison. So we're looking for a chair. So if you guys have any ideas, let me know. And I want to thank my wife, who, Dr. Hu asked me on Thursday if I could come and speak, and she was gracious enough to let me come and speak today. Thank you.
So thank you all so much for 3 really informative, wonderful talks. And I think the message out of all of this that resonates the most with me is really the last point that you ended on, is just how much hope there is in the field right now, and that I really feel that, and I hope all of you do too. So with that, we'll take some questions. We have about 20 minutes for questions. Any of these folks. So if you have a question, please head up to one of the microphones.
How do we get involved? I got a type 2 tumor, or had, and I got a spot in my lung and in my brain now that's just been viewed. So I'm very interested in, obviously, the immunotherapy trial. What do we do? How do we get qualified?
Well, we'd be happy to see you in our clinic at any time. Dr. Patel and Dr. Hung have very active clinics Dr. Patel sees lots of patients with uveal melanoma, and so you could just call our offices, and we'll come up and give you the numbers, and that you can hopefully quickly get in our emails. And sometimes patients say that it's hard to get in here because there's a lot of paperwork and stuff, and we're trying to make that much easier. But if you have an issue, you just contact us directly. We'll work very hard to get you in here. What people say once they get in, it's wonderful, but sometimes it's hard getting that activation energy to actually get your first appointment. Can be challenging, but let us know if there's any issues in getting in. We want to make it easy for you.
Sure. And I was just talking with Dr. Patel. Dr. Patel has cards with phone numbers for the clinics if you want to call and make an appointment. And then also the MD Anderson Facebook page has contact information. So if this computer has internet, I can pull that up right now while we take the next question. Does it have? Okay.
Yeah, our department, our melanoma department, actually has a Facebook page and a Twitter site, so we can. Yes, thanks. Yes, please.
Yeah, go ahead with your question.
There was recently an article, I forget where, probably the New York Times, that reported on a new way of looking at cancer spread, in that it stated that if the cancer cells are satisfied and happy, they don't want to spread, or they don't spread. And so there was a new look at whether anti-angiogenics is the correct approach. Rather than stopping the blood flow, stopping nourishment and everything, maybe we should feed it and let it stay where it is instead of spreading. I'd like your thoughts about that.
Well, that's a really good question. I think that kind of harkens back to why there are so many approaches and why there are so many different pieces of equipment. Part of what we do when we're delivering chemotherapy or immune therapy is we do want good blood flow. We certainly want the chemotherapy to get to a tumor bed, or in the realm of immune therapy, you want the tumor bed to be open to these immune cells coming in. So as someone else kind of alluded to, I think Dr. Hu mentioned, when you start combining things, you do have to be careful that you're not combining an anti-angiogenic with something that you want to poison, and then it might end up in the wrong tumor bed, or give somebody an immune therapy with a treatment that we know actually quiets the immune system. So I don't know that we know enough to say that anti-angiogenics should not be used, but we have to be thoughtful about when we use them and why we're using them.
I think as Dr. Hung, Dr. Pale were saying, we got to personalize these therapies. So in some settings, probably an anti-angiogenic is not to be used, but in a setting where you have a metastatic tumor that has a lot of angiogenic growth factors expressing, we can see all that with analysis. So if there's a lot of what we call vascular endothelial growth factor being produced in that tumor, or interleukin 8, or many things that can stimulate blood vessels, we're going to want to block that. And I think that will be the right answer there. And we're even seeing that blocking those angiogenics factors will stimulate the immune system for the most part. That's what we're finding, is that those growth factors that grow blood vessels also keep T cells, immune cells, from coming into the tumor. And we're learning that if we do that combination of blocking that with anti-VEGF, which is called Avastin, plus immunology, immune mechanisms, so that may even be better. So that's the next study we're going to have Dr. Hong do, is actually Avastin plus ipilimumab for uveal melanoma. I think that would be a nice study, Dr. Hong.
Also, what do you think of the idea of the most important cells in the tumor to kill are the stem cells, and the others are irrelevant? Is that a concept that makes sense?
Yeah, so this is a theory that is being investigated very heavily in most cancers, and that's there's a cell that's a regenerator cell, and that's the one called the stem cell that we have to kill, and there's other cells that are just hanging out that aren't as important to kill, but if we can kill that generator cell, it's the most important thing. The problem with melanoma is that there are a number of studies that show there really aren't those two populations, that every cell of a melanoma can be a stem cell. So that's a lot of those, there have been a number of models that have shown that when they dilute out the melanoma cells and they just give one melanoma cell to a mouse, it can become a tumor. And that's the challenge of melanoma, and that's why it can spread so readily, is that it's different from these other cancers like colon cancer and breast cancer, where you have these stem cells. Melanoma, pretty much a lot of the cells are stem-like cells, and so we've got to probably kill them all. But I think we can, and I think we can with targeted agents, immunoagents, and if we put them together in the right way, I think we can control this disease.
Thank you.
Thank you for those excellent questions.
So up on the screen, you'll see the MD Anderson Melanoma Medical Onc Facebook page, and there's the phone number for the clinic, right? That phone number up there is for the clinic. So it's, for those of you who can't see it, it's really small, 713-792-2921. Yes.
Hi, it's very encouraging to hear about all these clinical trials that are available. This is kind of a broad question, and it needs to be tailored to the individual, but in general, how does one choose the correct clinical trial that would be most effective?
That's a really, really good question. It's not an exact science sometimes. In my clinic, for example, most of the patients who have been sent to me are not eligible for phase 2 or phase 3. So they've already been told, you've had, phase 2 and phase 3 studies are often done in patient populations, for example, who've had no prior therapies of any kind. So they're, or they've had maybe one line of chemotherapy of some sort. Most phase 1 studies, those patients have exhausted all the therapies, and their options are either go to hospice or they come to me. And when I see a patient, there's a number of factors that we take into play. Increasingly, we are seeing from the melanoma group and other groups here where they come in with a molecular profile. I have a 46-gene analysis of what mutations they actually have. And then I have a list of protocols, about 128 protocols, but they're not always open because they're constantly opening and closing. We will put 3 to 6 patients on the study, and then we'll close the study for about a month, ensure that everybody's doing okay, and then reopen the study. So at the time that I see the patient, I kind of look to see which trials are open, see if any of these studies, 1, may target that molecular abnormality, and 2, we've also seen activity in maybe that subset of tumor type. And then really the two other criteria are, do they meet the eligibility criteria? Because these protocols all have very stringent eligibility criteria. Your labs, your maybe patient past medical history are all included in that. And then finally, which is an unfortunate hurdle, and hopefully the landscape on this is maybe changing a little bit now with Obamacare and everything, but we have to actually ask for financial clearance. All clinical trials will have to ask for financial clearance. In the United States, it's interesting, clinical trials are paid in two ways. The drug companies will pay for the drugs and anything associated with research, like a research biopsy, the research nurse, et cetera. But what's called standard of care, routine labs, CAT scans, et cetera, we actually have to ask your insurance company to pay for them. And some insurance companies have strict, and you need to look in your policy exactly what it says. It has strict policy lines, says, you know, if you sign this, you cannot go on to any clinical trial. Or you can only go on to phase 3 clinical trials. Some states have specific laws that says insurance companies must pay for that standard of care. Texas has that law. We passed one in 2009 or 10 or something like that. It's called Amendment 15. But I'll tell you, if you go to Illinois, if you're from Illinois, there's no laws like that. If you're from Alabama, it is really hard for me to get you on a clinical trial because there is no laws that stipulate that, and we just appeal to the insurance company. I will multiple times call the doc who's in the insurance side and kind of yell at them, you know, if I have to try to get these patients on the clinical trial. So that is kind of the complexity of getting onto a clinical trial. However, my understanding is, and I may be wrong on this, in 2014, Obamacare, one of the advantages, there are, my understanding, disadvantages and advantages of Obamacare is that they're going to require all third-party payers to pay for that standard of care so that patients do not have to struggle to get onto a clinical trial if they choose to. If you're on Medicare, that's not an issue as long as the drug is provided. But if you just have regular insurance, you really have to look at your policy.
And I just want to say that I think there's a lot of confusion about trials. Some patients will come thinking that a phase 3 trial is better to be on than a phase 2 or phase 1 trial. All the newest drugs, the most cutting edge, the most exciting drugs are actually in the phase 1, phase 2 arena. It's the older drugs that are usually in the phase 3, and sometimes on those phase 3s you get randomized against placebo, and who wants that? And so we actually won't even run some of those studies because we don't feel, you know, as David mentioned, the ethics of those studies are even of question, I think. So actually we focus mostly on phase 1, 2 trials. We think it's the cutting edge drugs, and that's what we have the majority of studies in our group.
Any other questions?
I kind of have a follow-up on the insurance thing. That was a good one. You really need to know you really need to read your policies carefully. And one of the advantages that we also had is that I'm a self-employed contractor, so I am the manager of our insurance policy. And one thing we never did is never renewed our insurance policy for better rates. So 10 years ago when she was first diagnosed, Blue Shield of California, hey, you can get a better rate, right? And I looked at the fine print. It was, well, they're going to limit services, just like that. One thing we found was interesting was that Pennsylvania, Blue Shield of Pennsylvania, Anthem Blue Shield of Pennsylvania has waiting periods and limitations on treatments. Blue Shield of California does not. So all the things she went through, Blue Shield of California covered. Lo and behold, Blue Shield of California in Pennsylvania had no limitations. So it actually worked very well to have Blue Shield of California in Pennsylvania. But anyway, but that's super important that I think we came out doing so much homework on our insurance policies, what they would not cover in the different treatments that she had went through was very important. So I urge everybody to, one, be careful with your companies if they're looking to change policies for a cheaper rate, be very careful of that, because there was a lot of pitfalls in that. So.
And try to and see, again, these insurance companies. I'm sure there are good insurance companies, but it's I'll tell you, in Texas they'll tell you oh, we don't know, we didn't realize that law existed. Oh, it exists, and we have to reiterate to them that it exists.
Yeah. And I also I encourage you to get involved legislatively. The Melanoma Research Foundation is very active in that realm. They visit people on Capitol Hill. So I think it should be something that should be required, that companies pay for the standard of care agents on a clinical trial.
I think we all actually, just wanted to jump in. I think we all have these situations where we have finally made a treatment plan and we've agreed on something and we're excited to move forward, and then the insurance company does come back. I mean, it's heartbreaking. I have a young police officer and his insurance does not cover clinical trials. And you are so, hogtied if you don't have those options, particularly in a disease like uveal melanoma.
I just want to thank you, Dr. Hu, for mentioning the MRF's work advocating on the Hill, and we're going to talk more about that tomorrow, and how you can get involved with that topic in particular. So why don't we take one more question and then we'll break for lunch.
Okay, I just want to see if I understand correctly. You had spoke about a gene analysis of 46 to 209 gene panel. Can you just talk a little bit more about that?
Sure.
And where is that done?
Yeah,
How is that done?
So our the institutional personalized cancer therapy is, you guys are doing that, right? So every patient, my understanding now that melanoma gets a new patient, they can order what's called the 46 gene ion torrent analysis, and it looks at close to 500 mutations and 46 genes. Eventually, they're going to, I think the institution will eventually move to what's called a 200 gene Illumina assay, which I don't know how long it's in the future, but that's where they're going to plan very soon. There are companies right now that will do that for you. There's a company called Foundation Medicine. It's probably the most cutting edge company right now. You just get on their website, foundationmedicine.org, and you give them you fill out their application. They will look at your tissue for you, and they will charge insurance. Now, some of your insurance will say no, and they'll come back to you all and say, well, your insurance says no, but it's going to cost you. Usually, I think the cost is around like $2,000, $2,000 to $3,000 now. So if that's something that you guys have not had done or want to do just to get a sense of what your molecular profile of your tumor is, you can do that through Foundation, or you could come here to MD Anderson and then see Dr. Hu, and he will order that 46 gene analysis for you.
Now, in the case of ocular melanoma, that would be for metastatic disease. So that would be for metastatic lesions.
Yeah, for the most part. And sometimes in that gene panel, there'll be aberrations we'll find that are actionable, which will tell us, oh yeah, you got to go on this trial with Dr. Hong because this is what it's telling us. And sometimes there won't be anything we can take action on at that time. But I think the only way to know is to try, and we are going to continually expand these panels in our institution.
And am I correct in saying that different institutions have different versions of this?
Yeah. Absolutely. We're going to really, in the next year, we're going to go to 400 genes. And as we get more of these sequencing projects done, maybe through the CureOM-sponsored Levi Garraway grant, we'll find out what all the ocular melanoma mutations are. We already know gene AQ, gene A11. We need to know about BAP1, right? We know those three things. But we need to, there are going to be others that might be important, and we could even think about one day making an ocular melanoma panel that's very specific for ocular melanoma.
Yeah, that's a great point, and we'll talk more about that tomorrow when we talk about Levi's grant. So I want to thank our panel. This has been a wonderful session. Thank you so much for sharing so much of your information. So I think we're pretty much on time, which is amazing. It is lunchtime now, and I think all of the physicians who have spoken this morning, including some who are speaking this afternoon, are around to have lunch with us, which we're really grateful for. So hopefully we'll have the next hour to mingle, have lunch. Lunch is out here. We'll bring it in here. And then I just wanted to put in a plug. As Dr. Hu said, the mindfulness piece of all of this is so important. And I know some of you probably feel tied because you want to hear the science, but you also want to go to the other session. So I just wanted to remind all of you that there is a session. We have a break from 5 to 6 before dinner, and there is a meditation and mindfulness session after the small group breakouts from 5 to 5:30. I know I'm going to be going to that one, and I just wanted to mention that because there is not a concurrent scientific session for that one. So I just want to put a plug in for that. So I think lunch is ready, and we'll convene in about an hour. Thank you. Thank you.
We don't know yet.
Yeah, I actually, I'm down. But yeah, that's our clinic information is on that page too.
No, it's from lunch.
Okay. I think that guy's fighting with me. He's doing it over there in the corner.
Hey, Robert.